Okay, great. Thank you, Akira. Welcome, everyone. I'm really excited to see a lot of you here in the room. And welcome to the second meeting of the Data Exchange Framework Stakeholder Advisory Committee. Just a few quick reminders. For those of you here in the room, we did order lunch for some folks ahead of time, and you will need to pay for that. So we will be over here at this table behind me. If you need to pay for your lunch, you can do that when we kick off for lunch. So just make sure you do that so you don't get in trouble for getting a free lunch. And then on camera, for those folks that are participating remotely today, we have a few committee members who are online. So let us know if you can't hear us. You can ping us through the chat or come off mute and let us know. But please do stay on camera unless you have a technology issue, or if you need to go off, please put the reason in the chat and return as soon as possible so that we can make sure. And if you do have comments or want to participate, please raise your hand or put in the chat, or you can always come off mute as well if we don't seem to be catching your virtual hand there up in the air. So a few housekeeping items there. And then I'm just going to quickly run through the agenda. So we're going to do some welcome and introductions. And then we will go into some department updates. So some kind of landscape things that are happening at the department that you all should be up on. And then we're going to go into program updates and purchaser contracting requirements, go into the Fast Healthcare Interoperability Resources Roadmap and technical standards. Then we have some time to talk about the Qualified Health Information Organization program. And then we'll go into some program issues impacting event notification. We'll have general public comment, and then we will wrap up if there's anything folks want to suggest for a future agenda or other things that we didn't hit on in the day. And there will also be an opportunity for public comment after each item in addition to the general public comment. So we will go ahead and I will hand it over to our chair, Dr. Jennifer Sales, to kick us off for welcome and introductions.
All right. Good morning, everyone. I'm Jennifer Sales. This is our second meeting. Thank you for coming back. I guess first, and I'm just sorry, I'm looking at my two sets of notes here. First, we have to do the quorum. So if you would kindly say you are present, if you are present, and I will note if you are online or in person, that would be fabulous. So I'm going to start, looks like we're alphabetical here, and we'll get going with a really exciting and meaty meeting. The team has been working hard on what we get to talk about today. So I'm going to go through roll call. Joan Allen.
Present.
You. William Barcelona.
Present.
Colleen Chawla.
Present.
David Ford.
Present.
Yvonne Chung.
Here.
Aaron Goodale.
Present.
Katie Heindorn. She's not here. Okay. Andrew Kiefer. No Andrew. Okay. Scott McDonald.
Here.
Ali Motoresi.
Present.
Eric Nielsen. I'm sorry, Eric.
I'm here.
Thank you. Mark Savage.
Present. Thanks.
Lucy Sins. Hi, Lucy. Kieran Savage Sagwan.
Present.
Me, I'm here. Julie Silas. Lee Tian.
Present.
Okay, then we have ex officios. Elizabeth Bassnett. Rebecca Fisher. No.
Present.
Oh, sorry. Okay. Amanda Levy.
Here.
Gianna Lauder Bianco. Anne M. Takamura.
Present.
No. Present on that. Okay. Couldn't hear that. Taylor Priestley. Taylor. Okay. Shannon Rohal.
Present.
Lynette Scott.
Present.
Jared Shineberry. Thanks, Jared. Okay, we definitely have a quorum. So before we jump in, I hear Akira is going to do a reminder of housekeeping, and then we're going to get going. Akira, over to you.
Okay, we will just remind you all that the in Bagley-Keene Open Meeting Act rules will be followed, which is why we're bugging you all about being on camera and doing a full roll call and all the other things that are important with Bagley-Keene Open Meeting Act. As noted, the members of the public can participate virtually or in person and provide public comment as well via either platforms. We have a podium in the room, and then also online, you can participate in public comment. Meeting minutes will be prepared after each meeting, and those materials will be posted on the website. We'll just note for public comment opportunities, they will be taken during the designated time after each meeting and general public comment at the end. Comment will be limited to the total amount of time allocated on a particular issue. And the chair will call on individuals in the order that their hands were raised or that they line up in the room. You are encouraged to limit your time to 2 minutes so we can hear from as many members of the public as possible. And individuals may, but do not have to state your name and organization at the top of your statement. Next slide. Again, members who are on site and encouraged to log in using their panelist link on Zoom. It looks like we have full success here with the folks who have come. And you just need to make sure that your audio and microphone are turned off unless you're talking, and that your room's camera and microphones are broadcast in the video and audio for the meeting. So you should be able to hear everything. If you have any issues or technical or logistical questions, please contact us through the chat or Akira at the email that is posted there on the slides.
Thank you, Athena.
And just quickly, yep. I think the last slide is the meeting participation options. We've kind of gone over all of this already, so I won't go through it all. But if you have any questions, please let us know, and please do raise your hand. And we will make sure that we're calling on both committee members that are virtual and members of the public during those comment period times. And that is all that I think we need to cover for housekeeping items, if I'm correct. So I will pause and see if there's any public comment.
We have no hands raised at
Seeing
this
none.
time, Athena.
Thank you. I don't see any in the room. Oh, and we now have Taylor Priestley is here. So we will log that attendance on our roll call. See, that's what happens when you're late. You get pulled out in front of everybody. So, all right, great. Well, I'm going to hand it back to Jennifer then to move on to the approval of the meeting minutes.
Okay, everyone got meeting minutes a bit back. So can I have a motion from someone on the committee to approve the meeting minutes back from April 16th, 2026, our first meeting?
Mark Savage, so moved.
Thank you. And then I need a second.
McDonald, second.
Thank you, Scott. All right. Now I've learned we need to go to public comment, correct?
Yeah.
Okay.
Or you go to committee comment first.
Sorry, any comments on the notes from the last meeting that we just approved? I mean, the minutes from the last meeting. No. Okay. Any public comment on the minutes from the first meeting?
No hands raised at this time.
Thank you, Akira.
And there's no one lined up in the room, so we can move on. We do to now vote.
Now we got to run the whole list again, right? Okay. Okay. So we're going to get to say present a lot today. We get to vote a lot today on things.
Let's just say.
Oh, I this time. Okay. Okay. All right. We're going to run same order. Joan Allen.
Aye.
William Barcelona. Colleen Chawla.
Aye.
Yvonne Chung.
Aye.
David Ford.
Aye.
Aaron Goodale,
Aye.
Scott McDonald,
Aye.
Ali Motoresi,
Aye.
Eric Nielsen,
Aye.
Lucy Sains, Mark Savage,
Aye.
Kieran Savage Sagwan, Jennifer Sales, aye. Julie Silas, Lee Tien,
Aye.
Rebecca Fisher. Oh, do they? Oh, you always don't get to vote. Sorry.
Yeah, we don't vote.
Okay, got it. All right. Sounds like we have full approval of the minutes. Excellent. Okay, now we're into the good stuff. First is Director. Oh, I'm sorry. I'm noting that the motion passes for the record. Sorry, guys. It's been a long morning. Now, the fun part. We get to hear some exciting updates from Director Landsberg. Thanks for being here and sharing.
Thanks very much. Good morning, everyone.
Morning.
Really appreciate you all being here for the second Data Exchange Framework Exchange meeting, and we're excited to continue the conversation. Thought we had a great first meeting. We have a lot of boards and commissions, and I usually give a few departmental updates at the beginning just to let you know some of a small sampling of some of the other things that are happening at HCI that we think may be particularly relevant to this group. So I have two updates today. The first is about the Distressed Hospital Loan Program. So a few years ago, the legislature passed and provided $300 million after Madera closed its doors. And we stood up the first distressed hospital loan program to 16 different hospitals. And there was concern again about some hospitals in imminent and significant financial distress. So the legislature passed and the governor signed on May 7th a distressed hospital small grant program with just $25 million. And we administered that in record time, and very, very proud of the team to 4 different hospitals: Southern Inyo Healthcare District, Palo Verde Hospital, El Centro Regional Medical Center, and Watsonville Community Hospital. And there's ongoing conversation about what to do about hospitals that are struggling financially. And so the May revision included a proposal for $50 million for distressed hospitals. The legislature package includes at this point $190 million, as well as the idea of setting up a sustainability unit to try to get at the longer term issues. So I think just as we do our work on data exchange framework, it's important to recognize the struggles that some of these facilities are facing, and some of the ways that the state is looking to both understand those struggles and also support them. The second main area of update that I wanted to give you all was about the Rural Health Transformation Program. So I mentioned it briefly at the first meeting as one of the areas in HCI's portfolio. And so this is $50 billion nationally, available over 5 years, authorized by HR 1. Last year and administered by CMS, the Centers for Medicare and Medicaid Services. And it's explicitly to change the way rural healthcare is provided and try to, they use the aspirational word of transformation and sustainability. It's been made very clear to us that this is not supplanting or replacing existing dollars. And we know hospitals and other providers will be struggling with the changes made to the Medicaid program under HR 1. So HCI put together California's application. We were awarded as a state $233.6 million for year 1. And year 1 runs through, it's on the federal fiscal year. And we are under some very tight time frames. So that $233.6 million is the 3rd highest in the country, but actually lowest if you look at per capita rural communities, because actually 82% of California is a rural community, and we have 2.7 million rural residents. So we are working as hard as we can to use those dollars as meaningfully as possible. So again, those dollars are designed to complement, not duplicate existing programs by really targeting gaps specific to rural health delivery systems, workforce shortages, and infrastructure limitations that aren't otherwise addressed through existing funding streams. So the California program is built around 3 integrated initiatives that have been approved by CMS. One we're calling the transformative care model, The second is around rural workforce development support, and the third is technology and tools, which may be of particular interest to this group. So under the transformative care model, that includes investments in regional hub and spokes model networks. We're looking to expand telehealth services, e-consult, and evidence-based care models, and strengthen local capacity to reduce avoidable out-of-area travel for care. So our focus is really to try to strengthen maternity and primary care provided locally, whole person care, and then connect to specialty care through e-consult and telehealth and the like, so that residents don't have to travel far for their care. So we're really excited to try to identify existing structures like that, help support them, and develop other hub and spoke care networks. All of these three components were developed with a lot of stakeholder engagement. The second component is rural workforce development. We heard overwhelmingly about the need to continue to build and develop the healthcare workforce in rural areas and build your own. And there's some exciting initiatives to do that, and we're excited to support them. So we will be supporting workforce pipeline programs, clinical training capacity, and targeted recruitment, retention, and relocation incentives tied to service commitments in rural communities. And then third, and very importantly, we have our health, technology, and digital tools component of the rural health transformation, and that will be investments in foundational infrastructure, including electronic health records, data exchange and interoperability, telehealth expansion, and cybersecurity. So together, we hope these investments will really focus on strengthening regional systems of care, stabilizing access in rural communities over time, and reducing the need for rural residents to travel long distances for their health care. So we think the tech and tools component is really integral to the ultimate goal of transforming care in rural areas. We are under some pretty tight timeframes. So all of the funds were freed or unobligated, or whatever the word was, Mike, by the end of March. And we now have to obligate those funds as a state by October 30th. So you'll be seeing some RFAs released by us in the coming weeks. By early July, the first ones will start coming out. Every one of the initiatives will have an RFA with an FAQ and a grant guide, and we'll be doing a webinar for each one to try to get it out. We've also been engaging in some very important tribal consultation with tribal communities, and there's a 5% set aside, which is a floor for the dollars to support tribal clinics and other healthcare services in rural areas. And so it's been very meaningful to do those tribal consultations. We're starting to try to get out into the field and visit some of those hospitals and clinics and tribal groups. We will also be establishing a Rural Health Policy Council, a public body like this one, which will include representation from rural providers and other community members. And we'll be announcing actually in the next couple of days that the membership for the Rural Health Policy Council and the date of the first meeting later this summer. So stay plugged in by subscribing to our newsletter. If you're interested, it's at our website, hki.ca.gov/rural-health. And then we just think it's going to be important for this group of the Data Exchange Framework Council and the Rural Health Policy Council to, there's some important synergies there around some shared interests. And so we will try to keep each other informed of the work of the other body. And with that, Madam Chair, those are my updates, but I'm happy to answer any questions or hear comments if anyone has them.
Thank you. That was super informative. Very exciting. Does the committee have any comments or questions for Director Landsberg?
Getting off easy.
Really? Okay. All right, we'll move to public comment. We start, I guess if you're in the room, up at the podium, if you're online, raise your hand. Akira will let us know. Not seeing anyone at the podium.
No hands.
Is there anyone online? Okay, you get off easy this time for sure. All right, thank you. Okay, well, right on time, and it means we can launch in now. So the Honorable Mark Valley is going to lead us through the next element of discussion, correct?
Yep, I'm going to start us off.
Okay.
Thank you, Chair Sales. Good morning, everyone. Thanks for joining us. I just want to start with a few programming notes, a few things to say by way of introduction for today's agenda. As you'll remember, we discussed at our last meeting that Senate Bill 660 requires this committee to make recommendations and provide input about specific topics, and that HCI is required to submit a report to the legislature by July 2027 that will include recommendations and input from this committee. And that those will also be used to advise HCI on administrative changes the department should make to advance the DxF program, and may also include recommendations for changes to state law, which the legislature may consider once they receive their legislative report. At the April meeting, we spent time both discussing the requirements for Senate Bill 660, as well as other topics of interest and import, and we labeled those strategic initiatives of the committee. Those weren't specifically required by Senate Bill 660, but this group believed them to be important to advancing the DxF program. The committee voted on those strategic initiatives. You see those results from that vote in the minutes of the April meeting. They're also on slide 13 of your slide deck for reference. And the intent is for HCI and the committee to continue to work together to determine how to address those strategic areas during our meeting time together and through other forums. And it was also suggested that we should plan to revisit these strategic priorities periodically. If you actually go back to last slide, slide 12, you'll see the committee meeting roadmap. This has been revised from the version that we presented to you at the last meeting. Per request from the committee, we added additional time for discussion of the collection of demographic and health-related social needs data. So what was scheduled for the August and October meetings now includes the December meeting for discussion as well. And then based on the committee's prioritization of developing a roadmap for fire adoption as one of your top strategic initiatives, we worked with the chair and agendized that as part of today's meeting. We did also want to discuss the process for adopting and revising technical standards more broadly for the program. There are already a number of these reflected in the data exchange framework policies and procedures, and incorporating fire as a technical standard can fit into that discussion, and that's part of agenda item number 4. Also part of agenda item number 4 is for the committee to consider if a separate work group should be established to bring together special expertise specifically to focus on driving technical standards, which can include fire. And so I wanted to note that for you all at the top of today's meeting. Then I also want to draw your attention to agenda item number 5, where we'll be beginning our discussion, our deep dive into the Qualified Health Information Organization program. Because we know there is a considerable degree of interest here, we have scheduled an additional public comment period prior to the primary committee discussion item. And so that'll give everyone a chance to share their views as the committee begins their discussions. And then we'll have, as was mentioned before, standard public comment at the conclusion of that and all of the agenda items as well. And then finally, last meeting, there was a request for more information about the listening tour that HCI conducted with stakeholders to hear feedback about the Data Exchange Framework program when it transitioned from the agency to HCI. And that has been included in your pre-read materials for members and is also posted to the DxF website, along with all of the other materials from today. So look forward to a fantastic meeting. Thank you all for being here. And with that, I'll turn it over to Jacob Parkinson.
Thank you, Mike. We can go to the next slide. Actually, go back just one more. Thank you. So since our last meeting, the DxF team has continued to advance implementation of the program across a number of different areas. We published revised FAQs in accordance with Senate Bill 660 to clarify a number of things. We would encourage you to go to our website to see those FAQs. We've developed a participant verification standard operating procedure to confirm the legitimacy of any new DSA signatory as a health and social service organization and select existing signatories, including those involved in legal action alleging data misuse, those subject to federal or state action due to data misuse, and others with publicly available reports suggesting that they may be bad actors. And through this new procedure, we will also be accepting complaints. So if you believe an organization is not an organization that provides health or social services, or a government agency, or a vendor that provides services to those, or if you believe they're misusing HSSI, or if they've signed the DSA in order to inappropriately access HSSI, we would encourage you to reach out to us with that organization's information so that we may begin a review. Next, we've concluded our DSA signatory grants program. As I mentioned previously, we've administered $50 million in grants to about 700 signatories to our agreement. That program concluded at the end of Q1 of this year. We're releasing final payments. We are, in the next few months, going to be releasing some updates to our participant directory policy and procedure to amend with minor clarifications on when the participant directory needs to be updated, and to remove outdated options to delay exchange. We'll also be conducting a broad outreach campaign to organizations who are required to execute our data sharing agreement who have not yet done so. And we're going to release some forms for DxF signatories to tell us whether they think we've misclassified them as a required signatory, and for organizations to tell us if they have any extenuating circumstances for why they have chosen not to sign the agreement. Lastly, we have one QHIO who is voluntarily withdrawing from our QHIO program. Until that is final, you will continue to see in our notes, the program is listed as having 9 QHIOs, but that may be subject to change. Okay, we can jump to the next slide. As a reminder, Senate Bill 660 requires certain participants to execute the data sharing agreement as a condition of contracting with DHCS, Covered California, and CalPERS. Next slide. Today, I'll be providing a brief overview of what those contracting requirements actually look like today. And we're going to hold more time early next year to have a substantive discussion of these contracting requirements, to hear your recommendations on what they should look like and any opportunities to align the contracts. But today, we're strictly going to focus on just current state, what exists. All purchasers, rather, meet the minimum requirements of Senate Bill 660 to require organizations to execute the data sharing agreement as a condition of contracting. But as you can see, how they've implemented other requirements can vary. For instance, Covered California requires participation in at least one QHIO as a condition of contracting. DHCS and Covered California require the exchange of ADT event notifications. DHCS requires subcontractors to execute the data sharing agreement. So these are some examples of how their contracts differ. And what I would encourage you to do is, as we work this year through a number of different topics that are relevant to these contracts, to start thinking through how we might improve these contracts over time, or align them across the purchasers. Again, we look forward to bringing this topic back with DHCS, Covered California, and CalPERS participating in a substantive manner early next year. With that, I am going to pass it over to Dr. Sales for public comment.
First, I guess I would start with the committee. Any questions or items for discussion based on the updates that he gave? Mark, you're on.
Thanks for the update. I did not take from the phrase participant verification standard operating procedure that it was also a place where the public could report concerns about whether there was compliance and so forth. So I'm just lifting up that maybe you want to have a more inviting name, tells the public that this is the place also. It's not just about verification that a participant is a participant. It's also a place to report items. Thanks.
Thank you, Mark.
All right, great. Lee, we're going to go virtual. Lee.
Hi. Yeah, I actually put my question in the chat, and it's sort of the same as overlaps with what Mark asked. Where I'm just trying to understand the standard is related to health or social services, and I don't know how transparent that determination is, or whether there will be consults with subject matter experts about, because it's a broad category, and folks have have concerns in the area, like say with crisis pregnancy centers and whether they would be eligible. So I'm just asking as a matter of how that process works, whether there's a way to understand how that determination is made. Thanks.
No hands raised at
Thank you,
this
Leah.
time. Seals.
Thank you, Leah. And I think it would be useful for us to circulate that procedure so you can see we've tried to be as transparent as possible about our current steps. It is certainly not a perfect process, but it is a process in which we want to start introducing a review to make sure that these are somewhat legitimate organizations, and we have taken action on the procedure with an initial organization.
Excellent. Thanks. Oh, David. Hi.
Good morning. I was curious, and I didn't see it in the written materials unless I completely missed it. Who is the QHIO that's withdrawing from the program?
Serving Communities HIO.
Okay,
IO.
and I don't want to put words in anybody's mouth, but do we know, is that just because they've joined the Manifest network, or is something else happening there?
We are still reviewing their request to withdraw and don't have details at this time of the exact specifics of why they're withdrawing. But we will share information as we finalize that move.
Okay, thank you.
All right.
We
Any
do
other
have one
questions
hand
online?
raised, Dr. Sales.
Can't see who it is. I can't see. So you'll have to say it, Kara, who it is.
It is Stephen Lane. Stephen, can you unmute yourself now?
Oh, that's public.
Oh,
Okay, we're going to move to public comment.
Okay.
So
My apologies.
let's hold. We have someone at the podium. We start in the room because, we honor in person. So would you like to start with your name and your comments?
Oh, I'm sorry. I think your mic is not on. Can you push the button? Thank you.
Oh, green is better than red. I'm sorry. Better for recording. Anyway, in the context of TEFCA, we've developed complex and rather extensive and now multiple iterations of vetting procedures to determine who qualifies as a provider to participate in the treatment exchange purpose. What we've noticed in that context is as we look ahead to more robust support for exchange for payment and healthcare operations for the engagement of other types of entities beyond providers, that developing those sorts of vetting procedures is pretty challenging. So I think we have an opportunity in California, since DxF specifically calls for exchange amongst other types of stakeholders and for other exchange purposes, in really thinking carefully about those vetting processes. So I love the fact, Jacob, that HCI is going to think about, how to review that. But I think we may want to look ahead to developing specific procedures and policies for how to do that vetting for new types of exchange participants. Thank you.
Excellent. Thank you. Do we have any other comments online? We've got Scott. He missed his shot, but we're going to let him speak now.
Yeah, I think the timing is good after this discussion of vetting of organizations. Something that's come up for us at our organization is existing relationships wanting to have their AI agents be accessing our healthcare data through various healthcare data exchange mechanisms. So I think as part of this developing a vetting process, I think we should address this issue around, are they humans or are they AI agents? that are accessing this data. It's a very new technology with a lot of risk and with a lot of potential benefit too. So, but I think we need to do this very thoughtfully and carefully, and make sure that the guardrails are in place so that if we do allow agents to access data on behalf of various organizations, they do so safely and don't pose any risk for privacy violations, et cetera.
Thank you for that. Can I ask for those folks in the room that maybe are on the committee that are not maybe highly technical and AI fluent, can you give an example of what that might look like? Or
the good use or a bad use, or both?
well, probably the use you're concerned about.
This one I didn't go into great depth on. This one I heard about this week, but instead of having a human spend the time to query organizations, say it might be a community-based organization querying a healthcare for discharges for a homeless person, maybe. But instead of having a human do that or review notifications, an AI agent could be doing that, which uses generative AI like Claude or OpenAI. Can be very flexible, but can be wrong. That it could troll various healthcare systems and say, who was discharged and what problems did they have, and what were your plans to get them connected to care in the outpatient arena, and then summarize that all so that, and it can highlight, the needs of that patient to the right care manager, say at a CBO, to say, Mr. Smith needs X, Y, and Z. Here's his contact information. Go for it. Instead of having to spend a lot of time finding those needles in the haystack. So that's a good use, I think, of it.
What are you worried about then?
Bad actors who may be using it for non-healthcare purposes, which we've seen a couple cases of in the media lately. And I'm sure lots of people would like to use healthcare data for all kinds of things that aren't related to doing good for our patients. And agents would make that very efficient for them to find patients that they want to take advantage of something.
Yeah. Thank you. Julie. Yeah.
No.
About the negative.
Just so you guys know, the
Got to be green.
button on the space is green, but then it turns red up by your mic when it's
Got it.
live.
Thank you. Kind of building off of what Scott said, when we work in the homeless system of care and sharing health data, a lot of that needs to be protected from law enforcement. People don't always want law enforcement to even know that they're experiencing homelessness. And so that has always been a big barrier. And I think that's a good example of anything that would increase that likelihood is an example of a risk.
Very helpful. Thank you. Aaron.
I just want to second Scott's comments. This is something that goes on daily, especially in the MSO world. We have AI companies actively pursuing business with every provider out there. Dealing with us, it's specifically around referrals, which isn't directly related to DxF here, but it's the same concept. And I think it's wise for us to think about what guardrails we need to put in place if that's something that we feel is a big concern for the DxF.
Great. Thanks, Aaron. Mark.
So I'll add a concern. AI may make some sense when we're dealing with people within the traditional healthcare system where the templates are already out there and everybody knows what the requirements are. But when you start getting to CBOs and social service organizations who are providing care, and people may not have programmed AI to think about some of those permutations, the opportunity for something to get wrong increases a lot. I would much rather have a knowledgeable human being doing that with people upstream in the sort of the community healthcare system and with individuals and patients, family caregivers, than an AI agent. That just scares me.
Thank you, Mark. Joan.
Just to pile on, adding one more concern. The concerns I've heard are all incredibly important. Just to add one more layer of wanting to make sure that we are not creating the potential for data leakage.
Mm-hmm.
We've seen around the world examples of AI systems that were supposed to not be able to leak, that either are acting in ways that were supposed to be outside their parameters or that are leaking data. And that we are trying to build something here that relies so much on trust, that this feels like someplace where we should go incredibly slowly and not try to break new ground on allowing AI access into the system.
Thank you. All right. Any other comments? All right. A lot to chew on, Jacob and Mike. Sounds like we can synthesize how that shows up in our thinking and work go forward. All right. I am announcing that Mr. Andrew Kiefer joined. Welcome, Andrew. Thanks for being here. Okay. Sorry, I have to figure out what's next. Oh, I thought we already did public comment. All right, apparently we have to go back to public comment. Any public comment in the room? No one at the podium? Any public comment online?
No hands raised at this time.
Okay, and Joan, I'm assuming your card, you don't have another comment, yeah? Okay, just checking. Okay, great. Excellent. All right, we're gonna move on. And oh, I'm sorry. Oh, we got somebody. Hi.
I apologize. Felix Su with Manifest Medics. I do want to comment as a follow-up on the standard operating procedure that was mentioned in the overview. Now, HCI recently introduced this SOP, which is intended to revoke problematic entities from being able to access data to the DxF. Unfortunately, based off of our experience, this measure will not work as fully intended, and I can explain why. So the DxF PNPs and the QHIO program specifically allow for and require exchange via the national networks and frameworks like eHealth Exchange and Carrier Quality. But exchange on these networks is governed by what is known as the eHealth Exchange DIRSA data use agreement, as well as the Carrier Quality Connect agreements, not the DxF. These national networks have strict reciprocity requirements that prohibit any of their users from selectively refusing to respond to certain other users. Now, because of that requirement, the DxF cannot prevent any organization, even one that is unverified, from requesting and receiving clinical information from another participant that has access to these national networks. So we just want to point that out for HCI and the committee to consider in perhaps revisiting how the standard operating procedure is designed. Thank you.
All right, excellent. Thank you. Okay, I think we're ready to move on. One note on public comment that I think I forgot to say at the beginning, if we could keep it to the item that's being discussed, because there's lots of opportunities to weigh in on the various items. And also to know that your comments will be heard. We don't necessarily have the committee respond. So just needed to say that out loud, I guess. Okay, we're going to move on to Jacob, and we're going to get into the fire topic that Mike outlined earlier. So Jacob, are you ready to go?
Let's do it.
Okay.
Thank you. And I think we can go to the next slide. As Mike noted, we're going to be holding some time to discuss the fire roadmap and our technical standards advancement based on this committee's recommended prioritization of discretionary strategic initiatives. So today, the focus of the conversation is first to review our current technical standards advancement process and what federal initiatives are currently in place to advance fire adoption. We're going to discuss priorities that this committee believes are necessary for our roadmap for fire adoption. And we're actually going to talk about and eventually vote on the process that we would take in order to develop this roadmap and bring it back to this committee for review. So at this point, I'm going to be turning it over to Rim Cothran to provide some background on technical standards, what's happening federally with fire adoption. And for those of you who do not know Rim, he has been in the interoperability space for a long time He began his HIE work nationally in 2004, leading one of the original implementations of the ONC nationwide health information network. He was involved in HIE beginning in 2010, leading implementation of California's approach to statewide HIE under the ONC State HIE Cooperative Agreement Program. He served as the initial executive director for the California Association of Health Information Exchanges, which created the California Trusted Exchange Network. It is California's first statewide exchange. He's assisted many federal agencies, health systems, state agencies, and nonprofits with interoperability, and he's assisted us on the DxF since 2021. We are very fortunate to have him with us today to serve as a subject matter expert and consultant on the DxF, who's going to help guide our conversation. Over to you, Rim.
Thank you, Jacob. What that history means is that I have a lot of jargon stuck in my head. Please yell at me if the jargon starts to slip out today. We are going to get to talk about FHIR, but first I want to spend a little bit of time talking about our standard process for advancing technical standards. The technical standards advancement process was established to consider changes to DxF policies and procedures and how we would exchange health and social services information. In general, the process does not seek to create new standards. California isn't in the business of creating new standards, and we seek to use federally recognized and national standards whenever possible. However, the process is designed to determine when we will start using certain standards as they emerge and mature. Examples of the types of standards we're talking about are HL7 messaging, which has been a standard in healthcare for a very long time, or the HIPAA transactions used by plans to exchange data on a standardized basis, as well as what are often called HIE profiles used by the nationwide networks, which is a structure for how some of the underlying HL7 standards would be used. The standards advancement process is an important mechanism that is employed by HCI today to ensure that DxF adopts technical standards and exchanges and for exchange at the appropriate time to meet what participants of the data exchange framework require and when those standards are mature enough to adopt. The technical standards are captured in our policies and procedures, primarily the data elements to be exchanged, which captures the types of data that each organization should exchange and the structure of those data elements or the terminologies to use. So for instance, that's where you would find a specification of what is the code set I will use for describing diagnoses. The technical requirements for exchange PNP describes how data moves. And so for instance, there you will find a specification that HL7 messages are used to send event notifications. We go on to the next slide. So the technical standards advancement process is a required process under our current PNPs. The technical requirements for exchange includes that requirement largely in response to stakeholder input in 2024 about the need for a standardized process to adopt new standards. CDII, who was operating the data exchange framework at the time, created the process, and it resulted from technical advisory committee input, stakeholder input from the IAC or the Implementation Advisory Committee that's active at that time, and other stakeholder input. Let's go on to the next slide. So this is a busy diagram, and I'm not going to read through all of this. It's in your slide deck. You can take a look at some of the details, but in general, this is a process that takes a little over a year and a half to go through. It starts off by what we're doing here today, that we start to collect priorities that HCI might advance in technical standards through stakeholder input. Then HCI would convene a standards work group, a collection of experts in the fields of those priorities to discuss what does and does not make sense for DxF and produce recommendations. Normally, those recommendations would be sent back to HCI at the end of this year. HCI would consider those, take more stakeholder input, and determine whether to make changes to the policies and procedures. Policies and procedures have a defined process for amendment. You can find that in our policies and procedures as well. It's a lengthy process, including stakeholder input through public comment. And then any changes that are made are then subject to a 180-day waiting period or longer, allowing organizations to adopt and implement those new standards. So it is a lengthy process with lots of opportunity for public comment and stakeholder input. Today is our first stakeholder input opportunity in that process. Just a little bit of history. CDII convened the standards work group at the time called the Standards Committee in 2024. At that time, charging them to look at the versions of US CDI, the US core data for interoperability standards, what version of those standards should be used in the DxF, and also to take a look at event notification and what standards should be used for that. That resulted in 2 amendments to the P&Ps. The data elements to be exchanged was updated to align US CDI version with the EHR certification process. And we have new standards for event notification that will take effect in August. So that again underlines that this is not a quick process that is intended to get out in front of people, but we had recommendations in December of 2024 that are resulting in changes next month. So, or in 2 months. So that gives you an idea of what this process looks like. Let's go on to the next slide. Again, where we are in this process today is at the beginning of it in Q2 of every year. And we're at the end of Q2 now. We reach out for stakeholder input, looking for areas where HCI should consider adoption of new standards that are maturing or emerging as important for DxF. The next steps is after stakeholder input, including today's conversation, in July or August, HCI would reach out to convene the committee if it determines to do so, and the committee, the work group would meet then probably through the end of the year in public meetings to discuss what might end up happening. Let's go on to the next slide. So, one of the things that Mike already talked about that we want to suggest we might consider for the the standards work group is to help us advance a roadmap for FHIR adoption. Just a little bit about FHIR. FHIR is an acronym for Fast Healthcare Interoperability Resources. You can imagine there are all kinds of side jokes about the use of FHIR. I will try to stay away from all of those today. The goal of FHIR is to modernize how healthcare exchanges data. Most of the exchange standards used by healthcare are rooted in very old technical standards. FHIR uses a much more modern set of standards that are used across many industries, and that means that it is based on some very mature technologies and industry that is adopting those types of technologies well outside of healthcare. The federal agencies promote, and in some cases are requiring the use of FHIR among healthcare organizations. And we'll talk a little bit more about some of those advancements. We go on to the next slide, please. And largely this is to just kind of ground you in what some of the other federal agencies and some of the other initiatives are doing along FHIR, which might help inform you about how we might consider adopting FHIR as well. I would encourage you, I'm going to try to pause at the end of this to see if there are any questions, but if anything that I say is confusing, feel free to interrupt me with a quick question also. We start with ONC. ONC, the Office of the National Coordinator for Health Information Technology, and I think they're going by that name again now. So ONC operates a certification program for electronic health records and has required FHIR standards be part of that certification program for some time. What that means is that providers that use certified electronic health records have the capability for FHIR, but ONC does not require the use of FHIR in any way, merely that the capability exists. The Centers for Medicare and Medicaid Services, or CMS, has really been pushing adoption of FHIR a great deal through a number of rules that they've issued. What's important to those rules, though, is that they apply to the plans that are regulated by CMS. Now, that's the majority of plans, but it does not reach out to the healthcare providers or other organizations. First, CMS issued the interoperability and patient access final rule. It was issued a number of years ago. It requires the impacted payers to make health information available to their members that may have apps on a phone or other device using FHIR standards. And if you look at the footnote at the bottom of the slide here, you can get an idea of who is included among those impacted payers. The interoperability and prior authorization is a more recent rule. Along with dealing with prior authorization, importantly, it requires that FHIR standards be used by payers to exchange data with each other, such as if I, as a member, am moving from one payer to another payer, the second payer can get information about my past history from my previous payer. It also requires payers to exchange data with healthcare providers, again, using FHIR. However, as I said before, CMS does not require healthcare providers to use FHIR to exchange data with payers. So that's a gap in the rule. And then most recently, CMS issued, and I think it is still a draft rule on interoperability standards and prior authorization for drugs. That proposed rule even may go as so far as to allow traditional HIPAA transactions to be exchanged using FHIR instead of the X12 transactions that a lot of folks are used to. So really looking at advancing the standards. What I will also add here, and Lynette can speak to this more if she chooses to, but DHCS has been using these rules and the need for the Medi-Cal program to use FHIR to promote FHIR among the organizations that they're exchanging with. So for example, the Ask Me initiative to stand up a repository for consent uses FHIR transactions to submit consent records into that repository and to request consent records from it. So using FHIR for that use. Let's go on to the next slide. Talk a little bit about the roadmap established by the Trusted Exchange Framework and Common Agreement, or TEFCA. TEFCA has published a roadmap. The link to the roadmap is here, and you're welcome to read it. It's not a lengthy document, but it quickly calls out 4 separate stages for adoption of FHIR. The first is really adopting FHIR content. Now, FHIR is a standard for exchanging data, but it does set standards around what the content of that data should be. And in the first stage, TEFCA is really focused on exchanging FHIR content. It allows qualified health information networks, or QHINs, the major nodes on the TEFCA network, to exchange FHIR data payloads using whatever standards they like to do that. So they are not necessarily standing up FHIR APIs, but they are exchanging FHIR payloads through other more traditional means. The following stages continue to advance that. First, QHIN facilitated FHIR exchange is really organizations that participate on TEFCA, allowing them to exchange data with each other as peers, not using the QHINs, and the QHINs are leveraged to help them make those connections. The third stage is QHIN to QHIN FHIR exchange. Again, the QHINs, the major nodes on the network, start to exchange data among each other using FHIR standards and FHIR APIs. And then the fourth stage is end-to-end FHIR exchange. So we're now talking about a hospital using one QHIN can exchange data with a plan using another QHIN with FHIR across that entire network. Now, what that does point out a little bit is that this is complicated. To get using FHIR the way it was intended, is a complicated process. We don't say, hey, everybody use fire tomorrow. And TEFCA hasn't called out a real solid timeline for adopting this, but is in stage 1 right now. So is very early in the stages of adoption.
Can I just ask on that? So you're saying they're in stage 1 and they have no timeline?
I am unaware of a public.
Yeah, I mean, it's just like, what does it take? Because I mean, in reality, a lot of these elements, maybe minus the fire requirement, but the exchange components are already in DxF. Like, so I guess
that's right. So what they're using today are more traditional HL7 and IHE profiles, and they're exchanging this data today. So this is a multi-year, but no specific timeline roadmap to transition from the traditional IHE profiles to also accept fire. They haven't yet even called out a timeline for deprecating the legacy standards so that fire is the only one that's being used. So this is going to be a multi-year process within TEFCA.
Can I ask one other question? This, you bring up here, the content component, like there's the pipes and what's the mechanism of exchange, and then there's what are you exchanging, right? Like what are the specific data elements that are there? So you're saying that in this roadmap, there's both a definition of what elements, like the data types that should be exchanged, in addition to the obviously technical
That's correct.
activities of the exchange?
I guess I would say that there are probably 3 pieces to this. There are the data that you're exchanging. So I will share my birth date. The format that takes, or the terminology. So how do I represent my birth date or a diagnosis? And then the technical mechanism for how I get that data to you. All of those are part of the fire standard. And the first stage is only to address those first 2 and not the how I get that data to you.
Okay. And then in your earlier slide, you said there is a current policy and procedure around the data elements that the DxF already has. So I guess my question is sort of how different is where we are now with DxF from where this fire set of data. I'm interested in I understand the pipe part. I'm interested in because I think some of the challenges practically that we hear are about, Ollie doesn't have claims data, like so-and-so doesn't have this data. Like there's different formats of how, like just making sure that the full robust data set of actual elements is consistent across. And so I was just curious, like, where do you see where we are with this? And is this going to help us, or how does that?
That's a really excellent question. So the data elements to be exchanged allows the use of fire data elements and fire terminologies, but does not require or promote their use. And so what we find today is that very few people are using them. So part of the roadmap is, how do we get to, I will let you do this, to let's move the ball forward and let's actually start doing it.
Thank you.
May I add to this your question?
Yes.
I think it would help to differentiate TEFCA from API exchange, because what you've got up there is about TEFCA, but what's happening on the API side.
So the when you get to stage 3 and stage 4, TEFCA is talking about using the APIs as well. But as you say, early on, it is really just about the data and not using APIs.
APIs, the current ONC regulations require the capability to exchange with fire APIs, both individual and bulk data.
They require the capability, but do not require the use.
Right. So and that's already in place. It's not a nascent stage 1.
No. Good point. Thank you, Mark.
Thanks, Mark. Julie.
Okay, I can wait till you're done.
Well, we're going to talk about gravity next, which might help a little bit too. So if we go on to the next slide, one of the other initiatives in place that's really promoting fire use is the Gravity Project. The Gravity Project is an HL7 accelerator program, largely looking at how to exchange SDOH data using fire standards. And because it doesn't suffer from the legacy of decades of old, outdated standards, Gravity started with the adoption of fire. Now, Gravity, I wouldn't say that what Gravity has is a roadmap. It's not a roadmap for the industry, but it is a tiered pilot approach for how any one organization would get into using fire. The first tier is basic information content and verification. So it is somewhat like stage one in TEFCA, although TEFCA is really looking at the exchange of those payloads. Tier one in Gravity is just get your data internally in line with the fire standards. Use the right code sets, use the right data elements, and break them up properly to get yourself ready for fire. So it is an internal only stage. The second stage is electronic information exchange. Get secure exchange in place and start to move fire payloads, but I don't care how you move them. It is somewhat like tier one in TEFCA in that move fire compliant data, but not necessarily using fire APIs. And then stage three is complete use of the fire data model promoted by Gravity and exchange. Gravity at this point also has implementation guides. So guidance for how you would use fire to meet certain use cases and exchange certain data to meet SDOH exchange payloads. Yes, Julie, I was expecting that to come back now.
I'm glad I waited. I have so many questions, and I feel like it's like, how do you ask social determinant of health organizations to meet the standards when they literally, HUD just took away all their money for their homeless management information systems, which is the databases they use. They've never been held to any of these standards. The quality of data is awful. They have to they get upcharged to use APIs. And I don't know about other social determinants of health systems that are county-based in California, but for sure, these are often county-anchored organizations, but they're not held and they're not funded to do the level of county-held organizations data sharing. So I'm really worried about like HL7, fire, like no way. I'm in a conversation right now with a managed care organization and a COC, and the COC wants to share data and the managed care, but they're being charged by the vendor for an API and they don't have the funding. So they're begging the managed care organization, just give us the money so we can pay the API so we can actually share. Everybody wants to do the right thing. But this stuff just is like, whew, and I think it's different when we're talking about Ask Me because it's going to be through a portal that the state hosts. So the burden on the social determinants of health organizations is lessened because the state is creating that standard and implementing the standard. And then our organizations have access to that. But asking our organizations to have the APIs to get event notification, to receive event notification is like, it's going to be impossible. So I'm just curious, is HUD part of this? I don't think so.
I think that what I would say is that you're raising really important questions here. And as we consider a roadmap, this is not how quickly can we force everybody to use fire? It needs to really be a discussion of when it makes sense and for what organizations and how you stage that and how you promote it, et cetera. So, and it was also going to be important to have the right players at the table having these discussions to build a roadmap.
Rim, we have questions, but just to that point, could you share what types of organizations currently participate in the Gravity project? I mean, are these, big health, like I think Kaiser participates in the Gravity. Like, I'm just trying to understand, to Julie's point, like what's the spread of?
So the Gravity project is intended to focus on SDOH information. So it has a mixture of healthcare and non-healthcare organizations They have a tendency to be the larger organizations with the bandwidth and internal resources to participate. There are a large number of vendors that are there that participate. I doubt that HUD is a member, and so this is not being promoted by some of the agencies in the same way that ONC and CMS are promoting FHIR for healthcare organizations.
Got it. Thank you. Mark.
So this is still just in the area of clarification, understanding. As I understand it, TEFCA requires participants to comply with HIPAA. And this is a public comment that I saw when I was working for ONC on their Advancing Health Equity by Design, my paper. And the comment was, many social service organizations and CPOs don't comply with HIPAA because they're not covered entities, but they're providing the care, and they are signatories to the DSA. So it's a big national conversation why we've got an API exchange approach and a TEFCA approach and what the intersections are. But for purposes of what we got to do in California, any thoughts on whether it's a problem to how much effort we should be putting into TEFCA, which is going to exclude people if they're required to comply with HIPAA, versus an API FHIR exchange? If that may be a sort of an artificial question, but I'd love to hear your thoughts.
It's not an artificial question. I don't think. I think that you're asking a good question that we should always be asking ourselves. Try to align with federal initiatives where it makes sense to, because it helps some of our participants move the ball forward. TEFCA was described here merely as an example of how one organization is moving forward to adopt FHIR, not a suggestion that we either adopt that roadmap or use TEFCA to get there. And so thanks for that clarification.
And just to jump in momentarily, in a moment, we will be opening it up to the committee discussion to help us set boundaries and priorities and timings for a roadmap for FHIR adoption in the state of California. So, Julie, your comments are prescient, and I think will help us to shape what that roadmap actually looks like and boundaries of that roadmap in just a moment.
Well, and this might be a good time to pass the mic, because this was last slide for me anyway, and so we're well into discussion here. So, Jacob, if you want to launch us on discussion, I think that might be appropriate.
Well, yeah, I think I've got a whole list here. Thank you so much for that overview, Rim. Scott, you are next.
All right, just from the de-jargoning aspect, I just want to just clarify things a little bit for people that aren't familiar with all this stuff. Kind of differentiating TEFCA, which is a regulatory way to say when we do certain things, from FHIR itself, which is how we can do certain things. And I just want to make sure everybody understands that that's a fairly mature infrastructure. Right now, we have really a Tower of Babel. And, lots of people try to exchange using different EHRs that don't have a common language. And the FHIR really provides the common language and the common way to speak. Sound vibrations in the English language is the analogy for direct human interactions there. And all TEFCA and Gravity and all these things really are just regulatory frameworks to determine when we should be using those or must use those, speak that language, when we should all speak English. So, anything that we do in California could be parallel to TEFCA and parallel to these other things, but mostly TEFCA. So I just wanted to make that clarification that there's kind of two big chunks here we can think about kind of separately.
Thank you. Very helpful. Ali.
Thank you. I think FHIR is going to be the future of the digital health. So it's great that we are having this discussion early in this committee, because I think that's where California needs to go. So I agree with Rim that it's a modern way of exchange, and it's targeted, it's efficient. enables the minimum necessity. Right now, we are all just sharing data, but not really adhering to minimum necessity necessarily. It's great that we are having this discussion at this stage. And also want to clarify, Jennifer, that Lynx does get claims in a fire format, just since it was announced in public forum.
Yeah, sorry, that's my example case. Okay, great. And I think what we're gonna do is we're gonna do Lee on the phone and Julie, and then there are a couple more slides that you have. Are you gonna do them? Okay, so then we'll move to Jacob because I think he's going to make sort of bring it back to DxF, and then we can talk more if that makes sense. Okay, so first let's go to Lee on the phone.
Hi, yeah, this is Lee, and I just wanted to not exactly echo, but mirror the comments that Julie made earlier about the situation sort of on the ground in local governments, because we definitely recognize how much pressure many of the local agencies are under as a result of the HR1, I guess. And there's just a tremendous amount of both demand for the services as well as a lot of pressure towards trying to not only move data around for serving clients, but also in order to meet eligibility requirements. My concern, though, remains that when disparate entities with very different capacities to do privacy and security, both technically and legally, are all trying to commit to sharing information, social determinants, SDOH stuff. A lot of that is going to be sensitive. And the cacophony, I mean, just as there is a Tower of Babel problem on the exchange, just trying to make that work, I think there's also a cacophony problem on the privacy and security side, where when standards are not clear, when there's different standards among the HIPAA entities and, say, local entities that are not even subject to a large portion of California state law around records privacy. I'm currently fighting over trying to apply the Information Practices Act down to the local government level, and I'm getting a great deal of complaints about how much it will cost for them to protect privacy in same way the state agencies seem to. And so this is just, to me, a very large actual privacy, security, data leakage problem that is, not the same as the AI one we are talking about, or but it's still going to be significant. So I just wanted to register that concern about privacy and security around SDOH data. Thanks.
Thanks for that, Lee. Okay, we're going to go to Julie, and then we're going to take a pause and let Jacob go through. And then at that point, if it's an old card up, put it down. And then we'll know who to ask after. Okay, Julie.
Thank you. I just want to address the comment that Mark made, and I think Lee is kind of getting at it as well, but HIPAA does allow non-covered entities to share data with managed care organizations and vice versa for care coordination. There's an FAQ out in 2023. We have AB 133 that allows that in California. So just wanted to say that, and also for treatment, payment, and operations. And we have now many small social service organizations who are also contracted to provide Medicaid services, because we now cover non-health related, health-related services. So I just want to be really clear that even though once it leaves the managed care organization and sits in the non-managed care organization, it's not covered under HIPAA anymore, even though it was covered when it was being held by the HIPAA covered entity for care coordination. So I think we're just in a different space now from under the Biden administration, where we were actually creating policies that allowed more care coordination and allowed SDOH. So I just worry that there's a little bit more opening in policy, but we're also narrowing the function, what's going to be feasible in practicality when we talk about all these things. So it's a balance. Thank you.
Thank you, Julie. Okay, I'm going to hand it to you, Jacob, to
Thank you, and we can go to the next slide. Just to bring this back to the DxF, thank you, Rim, for the wonderful overview of what's happening. I don't actually need to make a robust case for the adoption of a roadmap for fire because you all made that case at the last meeting. But just to summarize here, there is a lot of growing momentum behind fire federally, and adoption is growing across the nation, but it is still very limited in use in the state of California. Many organizations are continuing to rely on legacy exchange methods like IHE profiles that are required by nationwide networks, as Rim mentioned. QHIO adoption of fire can be limited due to lack of market demand and lack of DxF requirements. Federal policies are requiring fire, but largely for plans and not payers. And the TEFCA roadmap is advancing slowly and doesn't really account for all DxF exchange types or required purposes or even participant types. And so there is potentially some gaps in white space here that this state needs to address. We can go to the next slide. So we are going to open it up for discussion just to say our strategy for creating a roadmap might include some goals for transitioning data exchange to a fire standard. It might include the strategy for promoting or requiring the use of those standards in the DxF. And lastly, it could include some key milestones and timelines for which certain participants are required to start using those standards and in support of which use cases. So we're going to open it up to the floor. The question we have for the committee, what priorities would the advisory committee recommend be included in a DxF roadmap for fire adoption? Some things could include promoting the adoption of specific content standards or promoting the adoption of fire by specific participant types or even QHIOs. So we'll open it up for broader discussion.
Colleen.
Thank you. My comments might link what was the previous conversation with these questions. I want to underscore the challenges that counties and their partners are facing in adoption. So in San Mateo County, we are in a unique place where we're live with Epic in our health system, but we're launching Epic in other parts of our department, which touch the social determinants of health, things like family health services, behavioral health services, aging and disability services. We also have a live RFP out for QHIO right now, and so we're in a kind of a unique position for a county in an operational implementation experience that we can share and bring to this conversation. But we're also in a unique position because we can do it. I think that many county departments can't, and funding is the primary barrier, as not just for the counties that hold the work, but also for their community-based partners. A lot of the work that we did to help adopt the community supports, for example, is manual. It's all on an Excel spreadsheet. It's not something that can be easily transferred back and forth, but the information is crucial for what we're talking about. So I think that investment in the adoption is really an important piece.
Thank you, Colleen. Erin.
I just want to make a comment on the prior slide that it said that CMS has a requirement for fire, but that does not apply to the providers. But there's one use case that is carved out there, which is for prior auth. And what we're seeing is all of the payers making very large investments in fire technology right now, and they are downstreaming the prior auth fire API requirement to the IPAs in California, which is then creating an environment of for the IPAs on a very short timeline to look at making those same investments on obviously a much smaller budget and a much shorter timeline. And there is no other way to describe it other than sort of mass confusion at the moment, in that every payer has interpreted this requirement for fire and how they're going to downstream it to the IPAs in very different ways. And I think a role, if we're looking at a fire roadmap, one of the things that we would like to see is a role for this committee to provide some guidance, because there's no entity in California right now that can provide this guidance to the payers to help this conversation as to please pick one method that you are all going to downstream this requirement to the IPAs and provider groups.
Yeah, that's super helpful. And we have a speaking order. I did want to take the opportunity. I don't know, Lynette, I just was curious if you had any perspective, on this point that Aaron and others are making.
Well,
and just what's happening with DHCS.
Yeah, I mean, I appreciate hearing what's happening on the ground. Obviously, we're sitting in the role of being one cog in the compliance network. Folks have heard me say FHIR for a few years now. We had the 2020 interoperability patient access rule, and it said FHIR, and CMS said when they rolled it out, this is where we're going, this is what we're doing. So it is no surprise that we are where we are. But to the comments that people are making, well, what does that mean to actually operationalize it? What does it mean to actually do it? Especially since the way the shift happened from a CMS perspective was very different than high tech, right? So high tech came out and said, we're going to put a bunch of money into making changes in the health industry. So paying for electronic health records, supporting health information exchange, et cetera. But in September 2021, high tech ended. And so then it's really about how do we operationalize these costs into the way we deliver care. And so it put that shift on driving the transition through policy and through our program administration. And so certainly DHCS through our CalAIM initiatives and all of that work around coordinating care is driving that need to do so. But then in parallel, we have CMS giving these interoperability rules that says, okay, here's the standards we want everybody to use. So many of you have heard me talk about, to the extent that we want to identify funding from a Medicaid perspective that we can put into this space, it's either coming in this context of program delivery, or it comes in the context of our Medicaid enterprise systems, which means it has to meet these interoperability requirements, which means it has to use FHIR APIs. So if it's going to be part of a Medicaid enterprise system, it's going to have to use these requirements, or we cannot get enhanced federal funding. So there are definitely aspects of this around funding, around requirements, around oversight, and the CMS rules are pretty clear about Medicaid, Medicare, benefits exchanges, and their covered plans. So in California, that's Medicare plans overseen by Medicare. Our benefits exchange is not under that umbrella, but California has made choices in a variety of ways through DMHC regulation and other things to affect those, and the choices Cover California has made. And then in the Medicaid space, it's us and our managed care plans. And so again, for folks to keep track of, in the Medicaid space in California, we have contracted managed care plans. It's not just our comprehensive managed care plans, it's also PIPs and PAPs. So it's our county behavioral health, especially mental health plans, drug Medi-Cal organized delivery system, dental managed care plans, and our comprehensive managed care plans. So all of those are impacted by these rules and have these requirements. So there's guidance we've put out through behavioral health information notices and all plan letters in terms of trying to reinforce those expectations and the rules that we need to essentially oversee in terms of how that lines up. We're very excited about the work of the data exchange framework, how we create synergy. We want to really try to hopefully lean in so that we're supporting each other in these roles and responsibilities that we have. But, sitting in meetings that were being led by CMS over the last decade, where we are today is not a surprise. So it really is exciting to see the DxF taking on the idea of a FHIR roadmap, because we do need to sort this out. We do need to understand, where does it make sense to build? How do we use the structure independent of the FHIR API, of using FHIR as a way of structuring data and information to improve how we're communicating? So we're learning and growing with everybody else too. Really appreciate hearing the conversation here and sort of, thinking about how to take that back and how to apply it to the levers we have and the ones that we're responsible for, and how that fits into the broader equation.
Yeah, that's super helpful. And I'm just curious, do you have thoughts about sort of, and I mean, Taylor, you may as well, there's this piece about multiple plans and sort of like that, just sort of the rollout of what is expected. And I'm sort of curious, like, has this come on the radar for you all at DHCS or Cover California around like how, you tell plans, yes, this is what we want you to do or whatever, but do you see opportunity to like prevent some of what Aaron's talking about, or like how does that happen? Like how do we help the system?
I mean, it's a good question. We're talking about that internally as well, so I don't have a specific answer today.
Yeah.
But that's been part of the work over the past many years in the context of CalAIM implementations with the PATH grants and other activities that tried to help get resources into the communities, because this is new for a lot of providers. As Julie said, we're paying for things that healthcare is not traditionally paid for. So we have providers that are not traditional providers. So it creates a very different kind of environment. So
yeah. Okay. Taylor, is there anything you wanted to say?
Thank you. Yeah, similarly, I don't know that I have the most specific or concrete answer. I will say that we have tried to be increasingly thoughtful over the last few years, especially in thinking about both implementation rollout requirements taking effect, both for sort of the diversity within our plan portfolio and the diversity within the plans that we contract with, and then really as we think about their relationships with providers in the delivery system, we don't touch them directly. Our entire relationship is with those contracted health plans. We try to be really thoughtful about the diversity within the provider community, and we're sort of not even at the social services piece of this yet, given our plan designs and our benefit packages. So I don't maybe have a super concrete answer, except that we are trying to sort of keep our eye on what is an ideal end state to be at in terms of efficiency and abilities to communicate, and then maintaining flexibility where it is possible, and recognizing that the different resourcing and the different timelines that are going to be at play for different participants along the way, and really trying to think about like how are we setting up our plans for success as they have to roll those things out.
Yeah,
and take
that will work for providers. Yeah. Okay. No, that's super helpful. I mean, it kind of ties back into when Jacob started us off about what public purchasers, role in all of this is. So it sounds like you all are doing a lot of work there. It'll be good to dig in. Okay. I'm going to go back to Bill.
Thank you. If I can add on to Aaron's comments, representing delegated organizations here in California, the level of complexity is pretty daunting right now. If you're a large-scale delegated organization in California, you probably have 7, 8, 9, 10, 12, some as much as 18 plan contracts. Right now, we're seeing a lot of different varying directives coming from specific plans to adopt a prior authorization API by January 1 of next year. If everybody did that in California, what we've estimated is it would be about $500 million hit just to stand up the APIs, which may or may not be used by the downstream providers because they're still comfortable using X12. So there's a lot of things that we'd like this work group to address in terms of coordination around standardization with the MCPs, with the commercial plans, the MA plans, so that we can avoid cost escalation. Because on the other hand, we don't want to get into trouble with OCA if we have to raise our capitation rates and bump up against the 3.5 or 3.2% targets. So we've submitted a policy letter this morning to all 3 directors at DMHC, DHCS, and here at HCI, kind of specifying the complexity of the issues that face delegates, IPAs, RBOs, MSOs. Maybe I can pull a few more acronyms out of my pocket. I don't know, but ACOs. So anyway, I'll leave it at that. Thanks.
Thank you for that, Bill. Mark, you're next.
So in the spirit of what do committee members recommend? I see up there promoting adoption. I think we also need to be promoting use. So it's not, I mean, the building in the capability is where we have been for a while, and we need to actually get to use. And so I would say promoting use at least, not requiring use, because then we get into what happens when people don't have fire at all. There is that capability. The Gravity Fire Implementation Guide does provide for using fire APIs to exchange, so you don't have to have a fire server. But I'm not presuming that all of the people out in the community trying to provide care are going to have that. So at the very least, promoting use. I'm also concerned about the federal standard is read-only APIs for fire. I'm concerned about right access, right capability as well for patient-generated health data, for submitting corrections and amendments to a patient submitting corrections and amendments to the one's health record. I think this may be a place where California ought to lead the nation. But I'm being honest that it's not a part of the federal this standard. And lastly, I think sort of on a big picture recommendation, one of the slides towards the beginning had a roadmap of what happens when, which quarter, and so forth. And I have a recommendation to overlay on that what's happening, what the roadmap is federally, so that we can spot the intersections that are definitely happening, because we are expecting any time now the final rule for coordinated care from OCR, which is, as I understand it, is supposed to include something on this question about how do you have exchange with CBOs and social service organizations around the issues of HIPAA. And as a final rule, that's going to be something that's going to drive what we're doing. I don't know what it's going to say. I hope it's good, but it doesn't have to be. But to be aware of what's happening there and what we can leverage, or to just make sure we're playing, I think is a good idea. Thanks.
One brief follow-up question, Mark. Would you stop at promotion of use for all entity types? And Julie made a comment about requiring use for organizations that are underfunded might be a challenge. But some organizations have certainly been participating in high-tech funding and things like that. Would you stop at promotion of use for all types of organizations, or would you suggest requiring use of fire for any?
I think promoting use is intentionally a little ambiguous about that. I think we promote it as just as widespread as we can. There are ways in which a use of a fire API at the community level could be cheaper. So I recognize that there was no incentive program for community-based organizations, as there has been for providers and payers. It's a real issue, but I'm sort of trying to blend all those considerations, which are real, by at least saying, let's promote use too, not just adoption.
So because I think the question was also for perhaps healthcare providers or other segments of the market, that are not social service providers, like would you also recommend just
if they've got a certified EHR,
yeah, well, a lot of them do.
Then they've got the capability, and we should be promoting the use.
Okay. Scott.
Mark stole a lot of my thunder. I agree also that we should be promoting it, signaling that this is the future and this is where everybody needs to align. And that's because previous iterations of this effort has been, I think purposefully non-committal to any particular standard or technical infrastructure. And that's left a lot of people kind of out in the cold and not knowing what the heck we're going to do to comply with DxF. It's not in the DSA. So signaling that and saying, this is where you want to put your resources in the future as you have them would be very important. Starting to mandate it. I think along the lines you say about, certified EHRs, we probably need separate tranches of organizations that have different readiness while we figure out what do we do about I'm thinking trading partners without IT resources. And that's a large group of CBOs, smaller practices, et cetera, et cetera. And then we can figure out, hopefully at the state level, if there's some way we can support, something, portals or something, because it doesn't make sense for all those small organizations to be setting up their own infrastructure. But is there something communal we can do that they can leverage that can plug into this infrastructure of FHIR?
Great, thank you, Scott. We're going to Ollie.
Yeah, I think the good news is that the FHIR is less scary than AI, so kind of easier to tackle. Obviously it's another policy driven without funding, and CMS is driving it. Lynette has been talking about this for many years. So I think it's time to do the adoption, and there are ways of doing that. The concern that Julie brought up regarding the resources and lack of resources, I should say, is something that we hear a lot. And I think that's one area that the QHIOs can help in the transition, in a sense that we can become a translator from the old technology to a new technology for some of those that have resource constraints, whether funding or capability, until these organizations are funded or have the resources to actually adopt the FHIR directly themselves. So it's a kind of, I see this as a transition period for a few years until everybody is caught up. I think that's probably another way of looking at this problem.
Great, thank you. Okay, it looks like we have Yvonne on the line, and then we'll go to Lucy and then public comment. Yvonne. Uh-oh.
We can't hear you.
Okay.
Go to Lucy.
Maybe we'll go to Lucy and see if there's, I don't know if you're muted perhaps. Oh, no. Okay, Lucy.
So Lucy Science, CPCA. So basically we come from a health center perspective. And so I'm going to go back to what Mark was mentioning in terms of promoting use. Really, one of the things that I would recommend to be included is the use cases for value-based care. Because right now the health centers are getting a lot of documentation from these HIEs and they're not able to operationalize it. And so these health centers are being funded from P4P plans. And so we want to make sure that when we're creating these use cases as part of this committee, just really utilizing that going from document exchange to actually use of the data to promote P4P and value-based care. So that's one of the things I would recommend to be added to the roadmap.
That's great, thank you. Okay, we'll try one more time, Yvonne.
Can you hear me now?
Yeah.
Okay, great. Sorry, I had to fix the setting on my computer. I wanted to just add, so I agree. I mean, I'm not opposed to promoting adoption. I do have concerns around mandating it. I think speaking for our providers and particularly smaller providers, I think that the real barrier here, and I think what a lot of folks have mentioned, is really going to be the cost and the time resource on this. And so I think that I think for folks like skilled nursing, where they were not part of any previous funding for EHRs. I can't remember who had mentioned this earlier, but I think being mindful of having folks, how many technology upgrades we can expect from them over, in a period of time. So I agree that it makes sense to signal that this is the future, and if folks are making decisions now, they should be taking this into consideration. But I also want to just kind of be mindful that I really feel like cost is going to be, a significant barrier. And for a lot of particularly our smaller folks, they're buying, whatever is available. Their decisions are largely driven by the decisions that are being made by entities outside of themselves. So I don't think that there is any, active opposition. I don't think there would be a lot of active opposition to this, but, for purposes of just making sure that we are being, again, mindful of cost and, how this is all going to get rolled out, and, how much time they're going to have, if we do move eventually to a point where we are mandating adoption, we're going to need a long runway for them to be able to participate.
Great, thank you. Oh, okay, we've got Scott and Julie and Lucy. Oh, you're down. Scott, you're up.
Okay.
It's real. Okay.
Another quick consideration, along with all the financial issues, which we talked about a little last time, is the issues around consent and identity management, patient management. Those are also issues that will need to be addressed and should be considered when setting out any deadlines and timelines.
Great, thank you. Julie.
And just in a similar vein, we're going through a process right now where the same policies that's moving forward fire are also obliterating benefit programs. And so people are going to be losing their coverage, and the importance of being able to communicate and data share right now. Like, we do verification of disability in the homeless system of care. Suddenly now that's going to be needed to keep your Medicaid. So in the context of this, we also need to make sure we're not limiting participation, because now it's more important than ever to be sharing data across systems.
Thanks for that, Julie. Okay, we got Mark, and then we're running a little behind, so we may move to public comment if folks are okay. All right, Mark.
Sorry, I forgot to mention one larger recommendation, which is the roadmap should include monitoring and measurement. What's happening?
Yes. Okay.
Both baseline, so measure now,
Mhm.
and then measure the trends so that we know what we're dealing with.
Great. Thank you for that. Okay, so I think Jacob has like 4 pages of notes from this, so this is excellent. It's going to be a very detailed roadmap. Let's go to public comment. So if you're in the room and have public comment, would you come up to the podium, and we'll start there and then move online. Hello again.
Again, Stephen Lane. Since I'm here representing Health Gorilla today, I do want to point out that Health Gorilla is the only entity that is both a QHIO within the data exchange framework and also a QHIN within the TEFCA. So I have the opportunity to sit on the TEFCA Governing Council, which gives me a lot of insight into that process. So RIM was a little bit unclear about where we were on slide 26 in the progression of the TEFCA roadmap. And really where I think we are is in stage 2, because TEFCA is very much supporting what they're calling bring your own partner, where basically 2 TEFCA participants can exchange today using FHIR, so long as they have a direct agreement with one another. It uses the privacy and security standards of the TEFCA framework, but it is not a required response. It's how do we move towards bringing FHIR in as a more substantial part of TEFCA in the future. I also really wanted to echo what I think Ali said very eloquently, that FHIR is the future of health data exchange. There's no question. And the DxF, number of us have been saying here for a number of years that needs to be the direction that we go. The challenge has been within the QHIO community is that there hasn't been a clear business case for doing the technical development for FHIR, and we've heard about how expensive that can be. And I think the way we've structured the DxF, with largely not-for-profit, QHIOs, may not support that advancement until we figure out how to fund that. So I just think we'll come back to that later in terms of some of the challenges the QHIOs are facing. But I think FHIR is the future, and how do we get there given the structure that we've built? Thank you.
Thank you. Oh, okay. Hi.
Good morning. I'm Paul Redfern. I'm an executive with 211 San Diego, the Community Information Exchange, as well as San Diego Health Connect. I appreciate the robust conversation that we've all enjoyed, that you guys have had this morning on this very complicated subject. A few things. First and foremost, when we look at how we roll this out, I think that the important thing is that we remember the first rule, that is to do no harm. And in San Diego, we've been successful at bringing together a number of nonprofits, including our HMIS database system, by receiving funds from other areas and actually paying for that data. And so if you have a boots on the ground nonprofit organization, and that is the aggregator of the data, like our community information exchange, it allows us to plug in with our San Diego Health Connect, our HIE, to provide some of this information and translate it. Secondly, as we look for the technology roadmap and pulling together a committee for that, I would advocate that we bring in people from Gravity Project, including our CIE member and staff person, Elena Kalinowski from 211, who was a part of that, building that out for our community based on the experience that we've had in San Diego. And then finally, I think when we talk about accountability, we need to not only be talking about the successful exchanging of information, but the successful coordinated whole person care that our individuals are receiving, because it's imperative that we do not leave behind the social component and the social determinants of health as we talk about people's outcomes and health moving forward. Thank you.
Thank you. Is anyone on the phone? Okay, Jason, are you on the phone?
Jason, you can unmute yourself now.
Great. Can you hear me?
Yes, we can.
Yes.
Okay, thank you. Jason Buckner from Manifest Medics, and I just wanted to provide a little feedback specifically on the last slide of recommendations of how fire might be put in the roadmap. One item that wasn't listed in that that I think is valuable would be to roll out fire by exchange type and to start small. So rather than to tackle all of the complexities of all of the types of exchange, why not focus on the simplest one first, that being the exchange for ADT. We have already pushed forward a implementation of fire standards for ADT exchange. We've implemented that with several QHIOs, or in discussion implemented with several hospitals as well. And so rather than trying to sort of like tackle every one of those, I would say let's start small with something that's proven, works, and there's already a published spec for.
Okay, thank you. Do you have any other public comment in the room? No. All right. Very robust discussion. Athena. Is it lunchtime?
It is lunchtime.
Okay. No, there's no votes on this. There is a vote. Oh, shoot. I'm sorry. Lunch got in the way and we got excited. Okay. So we are going to be voting on moving forward with establishing.
And so very briefly, we have 2 more slides, and very briefly, just to say, because I think we're all hungry and want to go to lunch. As Rim noted, the technical standards advancement process that we already have could be a good way for bringing this roadmap to life. As Rim previously mentioned, this is largely composed of operational and technical experts. In the field, it's often 10 to 15 technical experts that are selected through an open application process. At this time, HCI doesn't actually recommend any additional technical standards for advancement, but the fire roadmap is certainly on our radar based on this committee's recommendation. We want to just briefly open it up to committee discussion if there are any comment on the approach for developing this fire roadmap. This would be through the standards work group, convened with 10 to 15 technical experts, and we would then bring that recommendation from that standards work group to this committee in early 2027 for review and discussion. Now, you all today set the boundaries and priorities of that discussion for that standards work group, but they would be getting into the weeds and building it out. So we wanted to open up for thoughts on that approach.
Aaron.
Just a question, Ren, would that be the same timeline we're looking at 1.5 years for the technical standards to get from, what's your thought on that?
Thank you. And so what the requirements are is that any changes to P&Ps have to have at least 180 days adoption period. What I would normally expect is in a roadmap like this that it would call out an adoption timeline that could be many years. I think that's part of the deliberation process, is to make recommendations about when milestones would be met. So
Understood. Just to clarify, the timeline for when we would see the roadmap from the
So
beginning.
when would you see the roadmap?
Sorry.
That would be early 2027. So the work group would convene throughout this fall and winter and provide a recommendation to you all in early 2027.
Does that answer your question, Aaron? Okay, great. Mark.
Technical clarification about something on slide 30, talking about the version of USCDI. There's there was an executive order and they have dropped sexual orientation and gender identity and changed the definition of sex in USCDI. We've actually talked about this before. I just want to confirm that we're going forward with, say, USCDI V3 or further, and we're not, for California especially, we're not deleting any of those data standards.
Michael Valley, Assistant Director, HCI. Mark, I think that makes a lot of sense. I think that's in alignment with other policy positions we've taken here at HCI with the administration. I might ask the work group to consider whether there's any impacts of that type of standard setting, choosing that version. But I think it makes a lot of sense for HCI in California. Thanks.
I think the impact would be deleting it.
Okay. All right. No. Okay. Any other questions? Okay. Oh, David. Ah, you're just so close. I'm sorry. You're in my blind spot.
I have a question just about what we're actually asking this committee to consider. I'm very sensitive to the funding considerations that have been brought up. I'll note in the last meeting, I was the lone vote that funding was the top priority. And I also was sensitive to Scott's comment about that we should stage how we roll out FHIR depending on the resources available to the providers. But my understanding from reading this is that would all stay here. Those are sort of outside the bounds of this committee. This committee that we're voting on forming is really just looking at what are the standards, right? It's what we, under the previous iteration of this work group, called I think the Technical Standards Committee. It's the very technical part of it. That's what we're talking about recreating.
So usually what we do is we convene technical and operational people there. So some of it is the operational practicality of adoption, but to your point that normally the committee would be mostly the technical, what makes technical and operational sense.
Okay, thank you.
So, David, am I reading through the lines that you would suggest that the timeline and the operational components be thought about in this context? Is that what I'm?
Well, I'm thinking that we're calling this a standards committee, but if we're asking them to start making these operational considerations about funding, about how we stage the providers, it's no longer really a standards committee. We're delegating the entire creation of the roadmap to this committee. And I just want to make sure we're clear on that, because I'm guessing that this committee, and by all means they can speak for themselves, but this committee may look at that very differently than saying, okay, we're going to get all the technical people in a room to figure out the technical standards. Mm-hmm. And I just, before we vote, I would think the committee would want clarification on what it actually is that we're voting on.
Mark?
Just confirming, as I read slide 31, they would be drafting a roadmap. That would come back to the advisory committee for discussion, amendment, whatever, but it would come back. It's something that sort of considers all the considerations we've been talking about today, packages them up, and then we have something concrete to work with, is my understanding.
That's correct. So David, to your point, this work group would be creating a draft roadmap, which would include milestones and timelines, including timelines for existing participant types based on the recommendations from the group today. But none of that would move forward until this committee has reviewed and provided comment on that concrete roadmap.
And endorsed in some way. Yeah. So, I mean, it sounds, I mean, I think the idea was to have a thoughtful, deep dive by a subset of folks and then come back and do exactly what you're saying, David, which is sort of talk about, debate, figure out, what might be real. Okay. Other questions or no? Okay. So, I mean, I'm going to read the language that we have about what we're voting on now. So the item before the committee is, should HGUI convene the standards work group in 2026 to develop a draft DxF roadmap for fire adoption for this advisory committee to review in early 2027? So is there a motion from anyone on the committee to adopt?
Second.
Thank you. All right. So, do I have to ask again? All right, now we have to see if there's any more discussion before we go to public comment and then we vote. Anyone else? Okay. All right. Any public comment that this committee should hear before we vote on this? I am seeing none. Okay. I'm gonna go back to my list. I gotta find it though. Do you have it? Thank you. All right, ready? Joan.
Aye.
Bill Barcelona. Colleen Chawla.
Yes.
Yvonne Chung.
Yes.
Oh, good, we can hear you. David Ford.
Aye.
Aaron Goodale.
Aye.
Andrew Kiefer. You online?
Can you put in the chat? We can't hear you.
Aye. Okay. Scott McDonald. Aye. Ali Motoresi. Eric Nilsson. Lucy Sands. Mark Savage.
Aye.
Kieran Savage Sangwan. Jennifer Sales. Aye. Julie Silas. Lee Tien.
Aye.
Okay. Wow. Unanimous. Excellent. What else? I think, do we feel good? It says we're done. Okay. What are our lunch instructions?
All right, time for lunch. So we encourage you to stay and connect with your colleagues. We're a little bit behind time, so we may cut lunch a little bit short, but I'll give you like a 10-minute warning, so don't go too far so that we can corral you all back. And again, we'll reconvene at 12:45. So we may give you a few more minutes since we're a little bit behind, but again, we have, if you've participated in the catered lunch order, your lunch will be here. You need to pay. So somebody will be up here at this table behind me to collect that money. And then we will transition back to open the meeting and reestablish a quorum at 12:45 or slightly after. So thanks, everybody. Enjoy your lunch and enjoy some time connecting with your colleagues, not talking about anything related to the committee.
Excellent. Thanks.
please. And we will go ahead and jump into the second part of our day. So thanks for being flexible and dealing with a slightly abbreviated lunch. We wanted to make sure we heard all of the robust discussion that was happening. So again, thank you for all of that. So we are going to have to reestablish a quorum. So we will hand it over to the chair here to do that again. So chair.
All right. We need 9 members.
Need 9 members.
All right. Joan Allen. You're here. Bill Barcelona. Colleen Challa. Yvonne Chung. You back on? David Ford. Here. Aaron Gooddale.
Here.
Andrew Kiefer. No, Andrew. Scott McDonald. Ali Motoresi. Eric Nielsen. Lucy Sen. Mark Savage.
Here.
Kieran Savage Segmon. Jennifer Sales here. Julie Silas.
Here.
Lee Tien.
Here.
Right. All right. So we have a really exciting afternoon planned. And we're going to talk more about QHIOs. And I'm going to hand it to Jacob to do that.
Thank you, Dr. Sales. You guys are stuck with me for a bit longer. We can go to the next slide. So the goals of today are really, we're going to provide a little bit of history on the program, but we're really going to focus in on the 2 primary goals of the QHIO program. And we'll provide an assessment on current state of whether we're meeting those goals or not. We'll then introduce some underlying issues impacting our ability to meet those 2 stated goals. We're going to hold time at the end for conversation with this committee on whether those issues resonate with what you are seeing with the QHIO program, if there are anything else that you see as issues that are worth addressing. We can go to the next slide. So today's conversation, and we'll just forward one more, there we are. Today's conversation is really kicking off a discussion of a series of meetings dedicated to the QHIO program and opportunities to advance and mature it. As I mentioned, today we're really focusing on the issues in the program as it exists today. We'll bring in event notification as an example of where many of those issues have come to light. In August, we'll actually be starting to talk about solutions and your recommendations to improve upon and address those issues. In October, we'll review those recommendations and how they relate to things other than event notification, broader parts of the program. And in December, we'll talk about plans to actually implement some of those recommendations. Next slide. So there are really 2 goals to the program, as I mentioned. First was to create a statewide network of exchange. And second was to help our participants meet their data sharing obligations under the data sharing agreement and the policies and procedures. Next slide. So we launched the QHIO program in 2023 with a very specific goal. We wanted to help participants by the start of exchange. On January 31st, 2024, organizations were required to begin exchanging under the DxF, and we wanted to get something live to help those organizations with their requirements ahead of then. Next slide. So we began the application process, like I mentioned, in early 2023, and we started that by identifying what capabilities would an intermediary need to properly serve participants and to support a statewide network of exchange. So when we opened up those applications, we specifically asked these intermediaries to attest to meeting specific requirements in the program. And due to limited time before organizations were expected to start exchange, and due to resource constraints and an inability to stand up something like a testing harness, we specifically relied on attestations from these organizations. We did not rely on demonstrations of capabilities. Now, following closure of the application window, we selected 9 QHIOs, and those were announced in 2023, in October of 2023, formally launching the program. Next slide. the application was split into three different content areas. First was organization, second was privacy and security, and last, functional capabilities. So we were specifically asking organizations to attest to whether they have the organizational structure, governance, the experience, the financial sustainability to properly serve participants, whether they had the data exchange environments and established provisions needed to protect our participants' data, and whether they had the capacity to actually meaningfully exchange data under the DSA and its policies and procedures. Next slide. Once we launched the program in October, we began meeting with the QHIOs weekly to start establishing connections between the QHIOs and address a number of other QHIO program topics. Those conversations continued when CDII transitioned to HCI. Next slide. And we've made quite a bit of progress towards our two stated goals that I had mentioned, but there is really a lot of work to be done. We have not fully met them, and I wanted to just provide a current assessment of where we are at in the program. So first, in our attempt to stand up a statewide network of exchange, we today have QHIOs who are able to exchange requests for information with one another. These are the typical query transactions with one another for treatment purposes, but support for other types of purposes like payment, operations, and public health is not supported. QHIOs today do not exchange via information delivery with one another, and event notification is only partially supported between the QHIOs. In the attempt to actually help all participants meet all of their data exchange requirements, several of the QHIOs today don't offer services to all required participants. Several of the QHIOs don't offer exchange of all data types, like claims data, behavioral health data, or social services data. And this is not a comprehensive list. These are examples of gaps in the program, gaps in our ability to meet all requirements for all participants. We will jump to the next slide. So HCI, with feedback from our stakeholders, has identified 6 core issue areas affecting the program. Now, these 6 issue areas are sustainability, service gaps, reciprocity, trust, voluntary adoption, and oversight limitations that can be found in your slide deck. I'm going to introduce each of these issues in just a moment. And for each, I will introduce some of the factors that have gone into that issue and how it's impacting our ability to actually meet our stated program goals. Lastly, these issues will be used to guide the recommendations from this committee to improve the program. So we'll jump into the first, sustainability. So meeting the needs of all participants is just incredibly challenging, given that every participant has their own different requirements, their own technology capabilities. They're all in different places in terms of where they've stood up their environments, and they all have many of different data types. Current program requirements are quite broad to try to meet as many participants' needs as possible. And some of those requirements don't always align with the QHIO's current business model. Some participants currently require services the QHIOs aren't structured or funded to provide. There's also no consistent funding model to support the broad range of participants' needs. Sometimes those who benefit from data exchange aren't always the ones who pay for that exchange, and that can create a financing gap that limits what QHIOs can sustainably offer. So just to recap here, the current broad program requirements on top of the significant capital and operational investment required from these QHIOs can put some organizations in sustainability risk. Next slide. As I mentioned, there are some service gaps in the program. We today are not able to meet all requirements for all participants adequately. In addition, so some of our QHIOs focus on specific subsets of the participant community. And in addition, they often also focus on specific transaction types that are useful for those types of participants. QHIOs are often slow to move towards adopting new services or new transaction types when there isn't an obvious market demand or funding model to support those services. There's also regional gaps in the program. Some QHIOs serve specific regions. Some serve organizations across the state. But what we see is there is some territorial fragmentation and there is some gaps in California that aren't currently met by any QHIO. Next slide. The third issue is reciprocity. There is an exchange imbalance between the QHIOs because they don't all offer the same services nor at the same volumes. And this imbalance can burden some QHIOs while benefiting other QHIOs. For example, a QHIO that serves the senders of event notifications, like an acute care hospital, can be incurring costs that are benefiting QHIOs that are primarily serving notification recipients, like a health plan. And this imbalance in exchange between the QHIOs is only exacerbated by the regional overlap because there is incredible amount of market competition between these organizations. And so any imbalance has a very high level of scrutiny. And that scrutiny often leads to reluctance or even refusal to collaborate. And it means we are not able to move towards comprehensive statewide exchange. Next slide. Next is trust. So as many of you are very clearly aware, QHIOs are required to sign the data sharing agreement, and many of their clients are required to sign the data sharing agreement and abide by the policies and procedures. But under those policies and procedures, participants are often relying on trust that organizations who are requesting data from them are doing so for a permitted purpose. But QHIOs today have no explicit role in monitoring the actions of their clients. They don't have any requirements on reporting on the use of their data or any abnormal patterns in exchange by their clients. And some recent allegations of inappropriate access and misuse by participants of a specific QHIO have led to other QHIOs limiting access to data to that QHIO. So this lack of trust due to privacy and security concerns is limiting our ability to exchange data between all the QHIOs and create a statewide network. Next is voluntary adoption. The DxF does not require all QHIOs nor participants to use specific technology, nor does the DxF require use of a QHIO. Today, over 30% of our participants have selected that they do not use a QHIO for exchange. So any efforts that we put in to create a statewide network of exchanges, excluding those 30% of organizations who are not using the QHIO. This fully technology agnostic structure has prevented us from creating this fully comprehensive network. And then we'll end on oversight limitations. So the DxF has limited oversight over the QHOs for a variety of reasons. As I mentioned at the top, we today rely primarily on attestations from the QHIOs that they are capable of meeting specific requirements. And we have minimal prescribed standards between the QHOs. We rely on them to establish their own exchange standards when exchanging with one another. And any disagreement in data standards and format and content can prevent meaningful collaboration between these organizations. With that, I'll pass it to Jennifer for Dr. Sales for a brief public comment.
Great, thank you. That was an excellent overview. Really appreciate it. Lots to think about. First, I'll open to public comment in the room.
Thank you.
She said public comment first.
And sorry, just to make one note, because of how important this topic is, as Mike mentioned earlier, we are opening up for public comment before and after committee discussion so the public can effectively introduce some thoughts that the committee may weigh in on.
Thank you. Again, Felix Su with Manifest Medics. We are, as many of you know, a nonprofit and actually the largest statewide QHIO, currently serving over 3,600 participants throughout the state. For this item, I especially want to highlight that we are not a member of the California Association of Health Information Exchanges, or CAHI. As such, any statements that are made about the DxF or QHIO program by individual CAHI members or the association as a whole do not reflect or represent our position. I really appreciate the framing that you just gave for the challenges that the QHIO program currently faces. Do want to actually hone in on the very top, which is that the actual stated goals of the program are to create a statewide network for exchange and to help participants meet their data sharing obligations under the DxF. From a sustainability standpoint, it is not necessarily to prop up any individual QHIO in the marketplace. In fact, the real problem is that due to the self-attestation basis for the program, many QHIOs have been de facto permitted to support too few services to actually meaningfully serve all types of participants. An even greater potential problem is that the program potentially allows some of these underperforming QHIOs, including those that are for-profit, to free ride on others while not supporting the overall cost of delivering data exchange services statewide. Now, as a ground reality, as you noted, the QHIO program relies on 8 companies that are directly competing to earn revenue from users and which receive no financial support from the state. But the program, today at least, attempts to oversee these competing businesses as if they were operated and governed as one unified infrastructure. Among other things, the program currently expects those of us that have historically invested in building more data connections and capabilities to give away, essentially, these advantages for free to our competitors. A key example is the ADT event notification, which you will discuss in the next item. And I just want to conclude by saying a forced cross-subsidy between QHIO competitors in this manner will actually perversely undermine the type of sustainability that really matters with the DxF, which is the long-term existence and reliability of a true statewide network for exchange. Thank you.
Thank you. Do we have anyone on the line?
We do have 2 people.
Okay. Do you want to, David McMahon? Is that who's on? Oh, McCann.
David, you can unmute yourself now.
Oh, so is that Steve?
Can you hear me?
Yes, we can.
Good afternoon. First of all, thank you for putting this online. It's very helpful. I didn't join at the beginning, and I hope the whole thing is available as a recording. So I'm speaking on behalf of 11 United Way 211s in California, all of which are and were DxF grantees. In this session on QHIO, I'd like to assert that in your 74-page roadmap, which you published in November of 24, you called out 211s as non-QHIO intermediary equivalents. And so it disappoints me that there's no forum discussion that I've heard so far about QHIO equivalents. And I think you need to be looking at not-for-profits who are also committed. There are 740 grantees to this program, but QHIOs are not the only game in town for interoperability. So right now, 11 United Ways are committed to making interoperability work. My input would be that the roadmap is a super tool. This forum is a super tool. But at the county level, where we operate 211s for 24 of your counties, the interoperability has to be at a county-by-county decision. And what we're observing is that we have to persuade and lobby HHS, social services, housing, sheriff's department in a county. If we're doing social care, we have to get the continuum of care to approve, which we've accomplished in Orange County. And so we can do data interoperability between multiple systems, and we have it up and running in Orange County with CBOs, the HMIS system, the 211, and we're working with CalOptima on 3 programs where we're focused on populations of focus. So I would have you think as a group to start looking at this, please, at a county ecosystem level. And instead of talking about a state-by-state or statewide problem, I would encourage you to look at pioneering counties and focus in on directing funding to cause success models in maybe 5 to 10 counties that are most inclined. And I would call out counties like Riverside, San Bernardino, Orange, Monterey, Merced, Fresno, Santa Clara, San Mateo. I think there's a set of counties where you can accomplish data interoperability And the QHIO isn't the only person in that community. The county agency is, but so are CBOs like 211. And so I'd love to see, not today because you're in James's lot, I'd like to see a follow-up discussion of how do 211s in a county get enabled to participate in completing your data interoperability. And we're working on it, but you need to fund a little more innovation because not-for-profits deliver social coordination, but there's no technology innovation funding to keep this work sustainable. Thank you.
Thank you for that comment. Okay, quick request for folks who are here for public comment in the back. If you want to make a comment, stand up like Steve is doing. Don't also register yourself online because online is where that's for the online people, and then we get really confused. Steve.
Very much. Just as a reminder, Stephen Lane, family physician, clinical informaticist. I'm here representing Health Gorilla, which is a network in good standing as a QHIO, a QHIN, and also a care quality implementer and a CMS aligned network. Here to comment on ADT notifications, which are themselves health and social service information and subject to required exchange under the DxF. QHIOs, as most of you know, are intermediaries to providers under the DxF and are required to send ADTs on behalf of those DxF participants. We're also obligated to send those ADTs under the Medicare conditions of participation. What's happened is a number of QHIOs have unilaterally and unlawfully blocked the sending of ADTs to DxF participants through the Health Gorilla QHIO. Health Gorilla received no notifications of these QHIOs regarding the reasons that they cut off access to ADTs prior to them stopping. There have been subsequent discussions about this, which are ongoing, but I just want to state that QHIOs cutting off another QHIO's receipt of ADTs is not safe for patients and their providers who rely on these to provide comprehensive and coordinated care. And it creates a risk of patient harm and violates state and federal law. Virginia is going to follow me with a little bit more detail.
Good afternoon. Virginia John, also representing Health Gorilla. I'm the Director of Compliance. In response to the outreach from Health Gorilla, San Diego Health Connect has been very instrumental in supporting us in re-enabling ADT's exchanges. So we're very grateful that they have complied and they have been providing ADTs since May of 2026. Health Gorilla is actively working on sending ADTs. So thanks again to San Diego Health Connect. They've partnered with us so that we can test our ADT outbounds. We've actually started that testing. We've successfully tested with them in test. We're proceeding quickly this week into production and with the goal of being able to provide ADTs by the end of the month to those QHIO entities that will work with us to make sure that we are supporting patients. Thank you.
Thanks. Okay. Akira, who do we have on the line?
Sorry. Could I, one more second? One more additional comment. I'm so sorry. We do request from the advisory committee, as we did the last time, as well as from the HCI team, to immediately put out a statement that it is unlawful for QHIOs to unilaterally cut off ADT alerts. It results in patient harm. And also establish a mandatory framework for QHIOs to resolve technical and compliance issues, including thorough investigation and adjudication, and require QHIOs to provide notice and legal justification before discontinuing from another QHIO. Thank you.
Thank you. All right, we're going to go to the virtual space.
We have Robin Roberts. Robin, you can unmute now.
Thank you kindly. I'm Robin Roberts, Director of Health IT Regulatory Affairs with Point Click Care. I'd like to start by thanking you for this item and section agenda. We largely serve customers in the skilled nursing facilities, i.e. nursing homes, and we certainly agree with the framing on slides 43 and 44 that needs to be a focus on those goals, and that the gaps that are highlighted there are certainly consistent with what PCC and our customers have experienced. Leaning into what David said, in looking at the directory entries, outside of the named QHIOs, even with the bit of consolidation that will happen with the one participant exiting, that directory shows 71% of participants have completed their directory choices, and there are 580 or 580 entries that identify as self or other. That means that they are not routing exchange through a QHIO, and I know David highlighted the nonprofit side of that with his aforementioned comments. But I just want to highlight that those organizations are quietly performing the same intermediary functions that the QHIOs perform. The rosters, the events, the notifications across numerous endpoints. Point Click Care is one of those organizations for our SNF customer base. We also have several relationships with existing QHIOs that are out there. And so we would like to see the framework formally recognize this category of non-QHIO intermediary so that we can continue to serve the 400,000 Californians that are in these facilities so that their data is not in a black box and we are not furthering the burden of the unfunded mandate to these SNFs. And that looks like a little over 1,160, I believe is what CAF confirmed last year, Medi-Cal dependent and Medicare certified facilities in the state. And so we would like to continue to advocate for recognition of that intermediary to help fulfill these functions because we do certainly support the DxF and these goals.
Thank you. All right, we don't have anyone else in the room. So can we continue with the virtual public comment, Kira?
Yes. Jason, you can unmute now.
Great, thanks so much. At first, appreciate Jacob's compiling. I think you did a good job of categorizing a lot of the key issues that many of the QHIOs have had. What I wanted to just quickly flag on the trust issue is Manifest MedX and certainly some other QHIOs, we're simply representatives of our participant community. And so when we talk about the trust and the concern with some of the other QHIOs and the allegations, those are not simply coming from us. Those are coming from our participants. We've had a lot of customers of ours, participants of ours, reach out to us and just express concern over where their data is going. And is it being used for the proper purpose that is being requested? So just want to flag this trust issue is not necessarily a QHIO to QHIO program issue. It extends to the participants and DSA signatories broadly. Thank you.
Thank you. I think we have one more comment on the phone.
Yes, we do. LGC, you may unmute now. Hello? LGC, you may unmute.
Okay, we'll have another round of public comment after the committee discussion, so maybe we'll come back then. All right, anyone else, Kira?
Nobody
On the
else,
line?
Dr. Sales.
Okay, thank you. All right, we're going to jump into some discussion and would love to hear folks' thoughts on the topic at hand, which is sort of what the challenges have been. You've heard public comment to give some additional perspectives. So would love to open up for that. I think our first card was Mark.
Is it okay to go back and ask clarifying questions?
Definitely. Sorry, you should do that.
So I have a question on slide 43, which is the program current state. And under goal 1, it's listed that information delivery is not supported. And since information delivery is part of the DxF and is required, I wanted to understand what that meant. Hear a little more about what's meant there. Not supported and yet required.
Yeah, and just to be clear, it's not supported as an exchange method between the QHIOs. Some QHOs may offer some forms of information delivery to their participants, but QHOs largely have suggested that there is very little market demand, at least in their current businesses with their current clients, for information delivery, and as a result, have deprioritized information delivery as a means for statewide exchange.
Okay, so I'll reflect on that, but that sounds a little bit like cognitive dissonance to me.
Thank you. Joan.
Just two quick sort of questions for understanding. One, on the 30% that are choosing, participants who are choosing not to use the QHIO, can you give us a little bit more flavor on who they are? Because it felt like I was hearing parts of it in the public comment, but is there just a little bit more broad description of who is choosing not to?
Everybody looked at me. You didn't see that, right? So I have better statistics on that for event notification. We'll hear about that a little bit later on. If you look across all of the participant types, there are examples of all participant types that aren't using a QHO. A large number of them may be disproportionately the CBOs, social care organizations, where QHIOs don't necessarily provide the services that they need, but there are hospitals that do not use a QHO. There are plans that don't, and plans that use more than one. There are, the labs are probably a good example that don't use QHOs for delivery of a lot of lab results, but do that themselves directly. And so and then ambulatory care providers are also represented there. I can't tell you proportionally for each one of those. I don't have that information at hand, but that's something that we do have the data. I just don't have it at hand.
Okay, that's even that level is helpful.
And just to add skilled nursing facilities to the list, as we heard in public comments, skilled nursing facilities often use a different vendor.
Yeah, I was just trying to get a sense of where are there systemic gaps or systemic solutions that we can put forward. And then the other question that I had was, as there are issues cropping up, are those reported to HCI or is there centralized reporting of those?
I certainly don't know if I would call it centralized reporting, but as we hear issues, those issues have shaped the 6 core issue areas that we defined. That is really an accumulation of all HCI has seen in those weekly meetings between the QHIOs and the accumulation of what we heard from the public.
Okay, so an informal but regular cadence of ways to surface issues. That's helpful.
Yep, that's right.
Right, thanks, Joan. All right, Aaron.
Yeah, clearly there was some pent-up demand for talking about the challenges with the QHIO programs. That's great. I'll have a few comments myself, but I wanted to start with the observation that the QHIO program has been a success from my point of view to date for what we set out to do. I think in the Medi-Cal world, the QHIO program is really the only pathway for data exchange in many ways. That is something that is affordable for health centers and is something that is easy to implement. And as we move out from larger provider groups to smaller provider groups, again, I see it as really probably the only pathway forward. And to date, there has been a measurable improvement in quantity and quality of data exchange in those entities from when we started several years ago. And I just wanted to start with that observation, and that we're going to hear a lot about the challenges, and I just wanted to frame it with the success first.
Yeah, that's That's very thoughtful. I would just, as you know, I know I'm mostly moderating, but as somebody who works with many hundreds of primary care practices across the state, I would say, I think maybe for an organization like yours at the intermediate or aggregator level, it's high value. I mean, I run a program for DHCS, the Equity of Practice Transformation Directed Payment Program. We have payments associated with signing a DSA and getting folks, on, and they don't even see the value completely given their current state of tools and other things. So I think it's important, I think to Joan's point, to kind of segment where the gaps are and like maybe a little bit why. But anyway, that's my 2 cents. Ali, I think you're next.
I agree with my friend Erin that I think QHIOs has been central to the success of DxF, and we continue to work on some of the problems that have been identified. The issues that have been kind of described here directionally are correct, but the QHIOs are not the source of the problem. I think it's just the design of the program. And you alluded to the program, not QHIOs necessarily. So it's the design of the program that needs some adjustments and refining. I think, when we look at the QHIOs, there are several components to this issues. Not QHIOs, not all created equal. So we all have different capabilities. I think the role of this probably advisory committee and the HCI is to bring everybody to the same level. With regard to, there are so many things to talk about the QHIO programs, but I think what needs, the lack of, it's a voluntary participation is one big problem. The ADT issue that has been brought up in different contexts, we don't know where those ADTs are going. We don't know who is taking action on those ADTs. I mean, those are, there are millions of ADTs that LENS is sending out. We don't know who is taking care of those patients. Because, we talk about transactions and all of that. We don't talk about patients. Are those ADTs, is the purpose of it is to real-time ADTs to somebody to take action. Not, that's what we enable. That's what QHIOs do. Enable patient at the time that patient needs intervention, then somebody is there to take care of them. Right now, we are sending these ADTs. We don't know, if it is being utilized to follow up with the patients and to do that intervention. So that's one aspect of it. The other aspect is this, the trust factor is important. I think, there's a reciprocal policy here, and with our good friend Dr. Lane and Health Gorilla, we've had, we would like to be transparent and talk about these things directly so we can resolve them rather than not having direct conversation. I think we're going through a process right now. I think Health Gorilla needs to show that their network is tight and our participants feel comfortable with sharing their information with their participants. So I think some of those things needs to be discussed and addressed. And I think we are going to be doing that with Health Gorilla directly. QHIO to QHIO data exchange, it's costly. Nobody's paying for this, and there's no standards, right? We don't have a standards. And so, but we are moving in the right direction. I think Jason mentioned that we are experimenting with FHIR right now for QHIO to QHIO exchange. And I think that's the right path to go. And I think we're going to make a good progress there. So I'm going to pause here and probably have more comments later.
Thanks. Thank you, Ali. And I did think it was important to level set that this part of the presentation is really around like the systemic challenges as opposed to like QHIOs aren't doing it right kind of thing. It's really, I think, I mean, well, as someone who collaborated with you on this presentation, I think really the thought was like, what can we get underneath to what's causing maybe and contributing to things not being the way that the vision is and in the QHIO domain, less than like this, a judgment on specific QHIOs. So just so it's clear. David, you're next.
Thank you. I've put a few thoughts on this, try to encapsulate them very quickly. One on the 30% figure that keeps getting kicked around. I do want to make sure we're clear that because those 30% are not participating in QHIO does not mean they are not doing data exchange.
Right.
Right. And I think sometimes we use participation in the QHIO as this shorthand for, well, they're not participating in QHIO, so they must not be participating. And it was always, if we think back 5 years to when we were hashing out the budget deal that became the data exchange framework, it was always envisioned that that would happen because we have a lot of larger entities, just in the medical space, we have a lot of larger entities that use the networks that care everywhere for data exchange and may not participate in a QHIO, but they're still participating. Because of that, the thing that I think I find the most challenging, and Ali just partially answered my question, is that what was always envisioned was that because we're a larger state, because we have so many people in such a diverse geography, that for the data exchange framework to work, we would have a federated model, a network of networks. And I think I find the most challenging in everything I'm reading here that QHIO to QHIO and QHIO to National Network Exchange, that has been so challenging because that was absolutely part of the thinking when we created the data exchange framework. Now, it sounds like there's something specific going on, some this trust issue that honestly I don't know or want to know about. But I do think I'm interested in sort of the structural things that are preventing that from happening because that was the centerpiece of the whole idea.
Thank you for that. Yes. Okay, we've got, Lizette. Oh, Lynette. Yeah, I was like, what are you talking about? It's, and she spelled your name wrong. No, Julie.
I have so much to say. So I'll just throw a few ideas out. I think we really need to think about the use cases. We're a few years in. What are the use cases? What are we trying to accomplish? As you said, thinking about the patients. I'm really unclear how QHIO works in terms of sharing data to know who they have in common with the participants. Are people sending CSVs with tons of people's PII, how that works? I'm not aware of how that works. But I will say that one of the things that the community that I work with, which is mostly social service organizations and counties, is they can't participate in QHIOs with some exceptions because of the cost associated. But there's also a level of trust in terms of right now when they do unilateral data sharing with their managed care organizations, they're sending over their entire membership in order for the managed care organization to decide which of those 10,000 people do we have in common. And then the managed care organization gets 4,000 match and then has to hold the 6,000 in a safe place, has to destroy it, has to certify it. And so we're standing here after you all have been doing all this stuff, and we're working in our community of practice, the health and homelessness data sharing community practice, where we're using a tool that was designed by Georgetown, which is open source, it's free, and it's encrypted data. And so you never are sharing PII that the other entity doesn't also have in common. So you're only sharing based on an algorithmic match. And so I would like us to think about not just because there's issues of trust, but also like questioning, is the solution as advanced as we need it to be for the purposes we need it to be versus what it was when we first created it? Because I think we've created a system with competition and trust issues that may not be solving the problems that it was attempting to solve. And there may be different solutions
that are new and fresh. And our idea of the community practice is to use this environment of data sharing between MCOs and homeless systems of care to get this tool in a place where we can hand it off to the QHIOs. And the QHIOs can start using it. It's open source, it's free, it's protected by Apache 2 license. So they can all take it when it's working at the level that we need it to work and use it at a higher functioning than I think right now the QHIOs are for being able to do the kind of data sharing that we really need to do with social services organizations. So I just want us to think about not only the problems as we currently function, but the problems that make us not function the way we are, and that looking outside and saying, how can we do it better? Not how can we fix the mistakes that are happening, but also how can we do it better and more effective for a broader community.
Thanks, Julie. All right, Lynette, you're on.
Okay, so I really appreciate hearing the conversation because I'm not as close to things as many of my counterparts here. So I really appreciate the conversation. Maybe to reflect a little bit like David was doing about what have we been trying to do? We've been trying to create the shared governance structure for a federated network of networks for 15 years. We started it off with a high-tech grant. We then moved into having KHI, the CalDERSA, with the policies and procedures around data sharing. DHCS actually had the first QHIO program under CalHOP, where we provided funding to help get folks onboarded to HIEs. And so we had some basic requirements around what it meant to be qualified. In that context, having the Q meant there was funding from DHCS and funding that came with tags, requirements, right? We had to have certain kinds of reporting. We had to have certain kinds of accountability, various kinds of things that were tied to it. High tech ended, and then the data exchange framework became official in California state law. So, I mean, we as a state have been working towards this for a long time. And I think given our size, our variation, we've always thought about it as a network of networks, which if we do that, we have to have some sort of governance structure for that network. And I think that's some of what folks have been talking about. So in that context, when I look to the queue of the program, it really is around that governance. So because folks have advocated and I agree, and I've been working in my own space to try to get there, that Medicaid dollars should be spent on data exchange. We have a bunch of hoops we have to jump through to make that happen. And so some of the principles of that are pay for things once. So I can't pay 8 different QHIOs for 15 million people each. I have to figure out how to divvy up 15 million people among the exchange intermediaries that are going to actually move data for the Medi-Cal population. So some sort of governance structure that helps do that and helps support that, and then also helps create some of those expectations around transparency, reporting, whether it's about the number of transactions moved, the cost of moving transactions, the standards that are used. So that governance piece, I think, is really important and one of the real values of the Q program, so to speak. As time has gone on, and we've seen sort of how it's played out, I don't think that we necessarily have to have every QHIO be able to do everything the same. So I think when we started this in the context of the data exchange framework, we talked about saying, well, every QHIO has to be able to do ADTs or has to be able to do XYZ. But maybe that's not the case, because we do have a number of organizations that are serving as intermediaries that don't have the queue, but maybe they're serving a specific place or a specific set of providers and those types of things. So is it that what makes the queue is the willingness to be part of governance, the willingness to share standards, the willingness to be transparent in services and pricing and capabilities, the willingness to be able to be engaged around all the risks we've talked about, whether it's AI agents or bad actors. You all may have noticed we're really focused on trying to identify bad actors these days. So these are things that are really important. I think that's where the governance piece comes into play. So there's a lot of opportunity there. And so maybe part of this is thinking about what are the commonalities we really need to have to to create a queue, so to speak, as opposed to what are the services specifically that folks have to provide. And that then also maybe creates a way of sharing workload. Again, working through the accountability and the reporting requirements are also a really important piece for us, certainly from a Medi-Cal perspective, because everything we do, we have to have that tied to it. So whether it's for our Medi-Cal members, whether it's based on the programs we implement through CalAIM and other program areas, or whether it's funding that potentially comes through to support health information exchange. But the whole idea is it makes a lot more sense to pay some number of entities to be in the middle, as opposed to for all of us to pay for hundreds of thousands of connections. So definitely focused on wanting to thread that needle and think it's really important, the work that we're doing here and the partnership that's happening across California to try to figure this out. So that's just a few thoughts for the conversation. Thanks.
Thank you, Lynette. All right, Lucy.
So I'm going to speak on behalf of all the California community health centers that we represent. So these challenges, Jacob, do resonate with what we're hearing at CPCA. I think, one of the health centers do believe in the value that QHIOs bring. That's something that we hear loud and clear from the community health centers. What we are hearing, though, is that they do continue to experience challenges with operationalizing the data, workflow integration, data usability, completeness of the data, the timeliness, and then the resources really required to, again, go to that operationalizing of this data. So we continue to hear that feedback directly from the health centers. So we really want to continue the focus on moving beyond document exchange, more like PDF, CCDAs, and really integrating that with their workflows. That really is going to support clinical care, QI, population health management, and really that value-based care. So those are the things that we're hearing from the California Community Health Centers that I wanted to share.
Thank you. Okay, Ollie, are you still up or?
Yeah, a couple of comments. One is that, ADT notification that had been discussed. California is kind of leading that effort because it's, nationally, a lot of organizations are working together, but California is kind of actually doing it. And I think we should take that as a positive, and then fix the issues that are related to the to ADT processing. The QHIO application program, Lynette mentioned the CalHub program. One thing about the good CalHub program was the application process, required that, those participating HIEs have, 2 hospitals. They had a minimum requirement of what type of organization they can support at the time that they were applying for the applications, whereas this was missing in the QHIO program. So you're dealing with the HIEs that, not necessarily have the, hospital, for example, participants, which is important for this type of program. So that's one. But I also want to remind ourselves that, we need to go beyond this interoperability. We are, lanes and other QHIOs are sitting on a lot of data that can be leveraged to help the providers and to help their patients. This is just ADT forwarding and CCD forwarding is yesterday, as my kids say. But it's, it's how do we leverage that data to take care of the patients, to reduce administrative burden. And so the regional QHIOs are really primed to deliver on that promise, because changing data is not the goal anymore. Leveraging the data is.
Great, thank you. Thanks for that. Okay, it looks like we're good with some discussion. So I think we will go to public comment and then I think we take a quick break. Is that right? All right. Is there any public comment in the room? Okay, no. Is there any public comment online?
Yes, we have David. Oh, I think. Go ahead, David. You can unmute yourself.
Thank you. All right. Thank you for the discussion on, the barriers and success. First of all, I've been in tech for 40 years. I've watched multiple industries pursue standards, and it is a slow and bumpy journey. And so while people are frustrated, I would tell you it's a long, multi-year journey. And the work that's being done under DxF, I think, is societally strategic. Don't lose faith. But I do think you need to broaden your approach, that there is going to be a multiplicity of approaches to exchange of data. I think that the geography of California, the United Way learning into the room, is that we've been studying 24 counties around social care. There are use cases that we've honed in on social care where you're doing the medical care and the QHIOs are heavily connected with clinics and hospitals. But the number one problem that the least privileged in our society are struggling with is homelessness, avoidance of homelessness, food insecurity, mental health. And I would tell you that we need to foster the notion that there's going to be a lot of innovation in multiple counties. And this journey is going to be many years, and don't give up, right? I'm a passionate supporter. And what you're doing is critical to shape what we do, but it doesn't have to be under one model. It doesn't have to be fixated on ADTs. It doesn't have to be fixated on QHIOs. We simply have to foster the outcomes that we want to cause, which is better coordinated care, which includes medical care and social care. So I would simply say, acknowledge the frustrations, create forums of experimentation, but I would really encourage you, as a closing thought on this frustration, treat the county as the petri dish of experimentation. We can talk about FQHCs, but maybe the FQHCs in Shasta County have got a very different problem than LA or Orange County. And so, rural health and urban health are different. So I would really have us think not about a statewide straitjacket, but a set of, we've got 58 counties in this state. You've got 58 petri dishes, and look for success in each county and actually publish successes and then knock down barriers at a county level. Because the action's at the county. Sacramento can set policy, but when the county hangs up the phone, the county decides what to do. So please treat the county as the petri dish of experimentation, but you are shaping the language, the taxonomy, the thinking, and what you're doing is societally good. So don't lose hope. Thank you.
All right. Thanks, David, for that inspirational talk and laboratory analogies. We really enjoyed that in the room. Appreciate you. Okay, we're going to take a quick break because our next one is quite a long session, we anticipate. So I know it's a little bit shortened, but just about 5 or 6 minutes. Get up, stretch, use the bathroom, and we're going to start again at 1:50-ish. So I'll call you all back. I know it's short, but I think it's good. Get your blood flowing after lunch real quick, and then we will get restarted for our final big push for the afternoon.
Time to hear all of the robust discussion. So I think at this point, we're going to jump back in and I'm just going to transition it straight back to Jacob.
Thank you, Athena. We can go to the next slide. We're now going to transition. One more slide. We're going to transition into a focused conversation for event notifications and its role in exchange in California's data exchange landscape. And we're specifically going to be talking about event notification because it's the one example in the QHIO program with a through line for all 6 of the problem areas that we were discussing earlier. So in a moment, Rim is going to be sharing our attempt to create a network for exchange for events and how each of the 6 problem areas have come to light as we've done so. Now, the scope of today's conversation is to talk about some of the requirements and the workflows for event notifications for our participants in the state, understanding how it's currently working and the current state of exchange across the different stakeholder types, how the QHIO program has both successfully benefited QADT exchange and how the limitations due to the barriers have prevented us from meaningfully taking this all the way. And lastly, we're going to preview some opportunities to address these issues before we close. With that, actually, one more slide. We'll bounce. The DxF roadmap does highlight a goal of statewide event notification, which is to enable a common statewide system that delivers timely health event notifications to authorize DxF participants to improve care coordination and whole person care. And the intention was to do this through a phased approach, starting with hospitals, admissions, and discharges, then moving to skilled nursing facilities and their admissions and discharges, and then broadening to other health and non-health related events. That could include something like a release from incarceration, a change in benefit status, or a change in housing status. Now, core to all of this strategy was leveraging the QHIO program as a means to build a statewide network of exchange for event notification. And any resulting conversation, we hope, should account for the core tenets of this strategy. Okay, with that, I'm going to pass it to Rim.
All right. So a couple of things before we really dive into things here. I want to underline that event notification is being used as an example to help us really understand some of the issues with the QHIO program. It is potentially a good example, as Jacob said, because it illustrates all 6 of the issues, but it also is not supported by the nationwide networks. So you're either using a QHIO or you're not. I will acknowledge that people are playing around with how the nationwide networks might support ADT, event notification, but they don't today. And that we have, good to Ollie's point, there's good exchange that's going on today where we can cite some of the numbers and really talk about numbers. So we are going to be talking about numbers here. We've talked about what the issues are in the QHIO program from a conceptual standpoint. Now we're going to dive into the numbers that show us that that is actually happening and where it's happening. We start with the slide here. I want to ground everybody in what event notification requirements really are, because it'll help us have the rest of this conversation. So forgive me for a little bit of a technical sidebar. The technical requirements for exchange define the operational and technical requirements for event notification. And there's a more complete review of the requirements in your pre-read materials. So I'm not going to go through all of that. You might pull that out, or if you want to see what the P&P says about it, that was in your pre-read materials as well. So we're not going to go into that much detail. Notifications today, as Jacob said, are limited to healthcare and are limited to admissions and discharge from acute and subacute care organizations. But we want to think about this in terms of broader applicability. Some of the details I'm going to talk about today are the outcome of the standards advancement process conducted in 2024, and we're going to talk about some of the standards that take effect in about 6 weeks. So just bear that in mind. Today, Hospitals and emergency departments are required to support sending event notifications. The standard for that is an HL7 standard, widely adopted by most EHRs today. And there are specific requirements for the data that they must send. Notifications are intended to include only the minimum data that lets you know what's going on with somebody. And if you want to know more information about the event, then you can request that additional information. So for example, the notifications of an acute admission or discharge includes the time and date and location of the event. It includes information about the person that was involved in the event. If it's an admission, it includes a chief complaint, if known. If it's a discharge, the discharge diagnosis and discharge disposition. It does not include detailed lab results, medications. It doesn't include any of that. And if you want to know that additional information, you can go get it. That's a direct response to a lot of feedback that we got from a lot of stakeholders. Don't send me data I don't want and haven't asked for. So for instance, my PCP probably doesn't care about a follow-up bunch of information from the time that I cut myself and went to the ED for stitches when carving the turkey, but would be interested in an acute event associated with a chronic illness that they're having trouble following. Hospitals and emergency departments are required to support requests for notifications. And again, this aligns with don't send me data I don't want. And those requests, they must support rosters, a list of the patients that I want event notifications for. They can receive requests by other means as long as both parties agree to it, but they must support rosters. Requests themselves must also have minimum information in them. They have to identify the person so that I can identify that Rim Cothran is an individual that I'm interested in events on, but they also must mention the organization that is requesting the event, and the notification, and must include the purpose, and it must be a required purpose under the permitted, required, and prohibited purposes P&P. So that means that I cannot request event notifications for research purposes. That is a permitted but not a required purpose, but I can submit them not only for treatment, but for public health operations. So there are a set of purposes, and they must be stated in the request. SNFs are also, skilled nursing facilities are also encouraged to send event notifications, but are not required to yet. As Jacob said, that's intended to be in our next stage. Finally, the technology requirements are intended, the policy requirements are intended to be technology agnostic. They don't say that you have to use any particular method. You may use any HIE network, any HIO, or any point-to-point connection that you choose to use. That said, again, the nationwide networks don't support event notification today, so most organizations are using either point-to-point connections or a QHIO to do this work. Let's go on to the next slide. And this slide builds, so if you want to go ahead and build it the first time, I want to talk a little bit about the patterns. And there are three primary patterns by which this happens. The first one is the simplest pattern. We talked about that a little bit today already. I, as a participant that want to get event notifications on a group of patients, send a request to the hospital. That request might be a roster or it might be something else. Now, as events happen, I have a standing request for notifications based on that roster, and the hospital must send me notifications when they happen in real time. So that is the most basic pattern. There is a lot of technology that the hospital needs to put in place to make that happen. They need to match the request to events. They need to format the event. They need to transport the event to get out to the participant. If we go on to the next pattern, well, there are organizations that can help with this, such as a QHIO. And we're going to talk about QHIOs as if they are the only intermediary today. They are not, but we're focusing on QHIOs. So in all of these diagrams, you're going to hear me talking about QHIOs. In this case, Again, I, as a participant, send a request like a roster, but a hospital has elected to use a QHIO to send notifications. And so I send that roster to the QHIO instead. Now, the hospital sends events as they occur. Many hospitals are doing this to many QHIOs today, and the QHIO does the work that the hospital would do in the last pattern. Matches a request to an event that's coming in, formats a notification, and sends it out to the participant. Now, if both the participant and the hospital are using the QHIO, there's just one organization here in the middle. If we go to the final pattern, and this is the one that we're going to try to generalize about today, well, what if the hospital and the participant aren't using the QHIO? Well, that requires that those two QHIOs send something back and forth. They need to share events and they need to share requests in some way. So the pattern for the participant and the hospital are the same as if they're both using the same QHIO. I, as a participant, I send requests, I get notifications back. I, as a hospital, send a stream of information into my QHIO, and the QHIOs do the hard work of coordinating. Again, you're going to see this third pattern pop up on all of the subsequent slides. Let's go on to the next slide, please. Well, I forgot that there was that other build. Let's go back here for a second. We had talked a little bit before about percentage of organizations that are using QHIOs. In the event space, about 80% of hospitals are using a QHIO, and about 85% of participants that are receiving events are using a QHIO to receive them. And that's based primarily off of what we see in the participant directory.
Ask a point of clarification.
Sure.
When you say roster, can you explain what you mean by that? If FQHC wants to know if any of their patients have an adverse event,
that would be, yes. So
is it their entire FQHC membership? What is the roster?
It is the list of individuals for whom I want to receive notifications. If they want to receive notifications on their entire membership list, then it would be their entire list. Typically, I suspect, and there are people here in the room that can correct me, a plan, for instance, would send their entire member list if they're interested in getting notifications on all their members. Whereas my PCP probably doesn't put me on the list because she is not closely following a chronic condition that I have.
Yeah, I would just say that, I mean, typically in the PCP realm, you've got your electronic health record, and that's sort of your easiest status of who your people are, and that's what you would use. And there are many tools and additional, technology that can allow that actually pretty seamless exchange.
Absolutely.
So, I mean, it's not like nobody's like making a hand list. Yeah.
Let's go on to the next slide, please. I do want to bring this home for a bit. A couple of years ago, we were running a series of webinars, and we talked in particular about the story of Lisa and Dr. Tom and how event notification might fit into that pattern of care. And the important thing here is that Dr. Tom can get an alert when Lisa shows up in the emergency department and can follow up at the time, making sure that the emergency department knows useful information about Lisa that might not be obvious in their own records yet. And it also means that Dr. Tom gets a notification when Lisa is discharged. If Lisa goes back home but needs to be followed up because this event indicates poor control of a chronic condition, then Tom knows that. And Dr. Tom doesn't find that out because Lisa finally showed up for another checkup, but finds that out more promptly after her discharge. So there's real value in getting the real-time exchange and making sure that this all happens. Let's go to the next slide, please. Now we've talked about how it works, and in really broad strokes, I want to talk about what the problem here is. So now I have a participant sending rosters to a hospital. And in the absence of QHIOs, that means maybe 4,000 participants are sending rosters to maybe 400 hospitals. And those rosters, some of them might have tens of patients on them. A roster from a plan may have tens of millions of patients on it. So we really are talking about something that when you don't have support of intermediaries or some coordination is not sustainable. So we relied heavily on the QHIOs to make this a sustainable process. Let's go on to the next slide, please. What we're going to do throughout this section is we're going to pause periodically to make sure that you guys understand what's going on and give us a chance to talk to some of the things. Here's our first time, is just to make sure that you understand what the process is and what the requirements are for event notification before we move on. I turn it over to the chair to handle any discussion that we have here.
Any questions? Ali, do you have something you want to say? He's going to wait. Okay, no. You keep.
Okay, were you all down with all the technical stuff? Let's go on to the next slide. So, as I said before, we spent the first part of the afternoon talking about QHIO issues. I think the issues that Jacob was talking about are things that everybody can understand, but I want to try to bring data to that. And I want you to understand where the data comes from and some of the limitations of the data and some of the assumptions that I'm making here. You'll see that a lot of these numbers are rounded off. I say 80%, I don't say 82.5%. And there are reasons for that. So first of all, a lot of this information comes from the participant directory. This is a place where participants voluntarily identify how they are exchanging data. 71% of participants have completed their participant directory choices. So that means that I have a 71% sampling of participants. When you see numbers from me, I am assuming that that missing 29% has the same division of how they're exchanging. I don't know that to be the case, but that is the assumption that I'm making. The QHOs report on how they're exchanging data quarterly, and some of the numbers in here come from the Q1 report. It is somewhat a preliminary analysis of that report. We also conducted a participant survey, and there's information here from that survey. Very, very few hospitals responded to the survey, so there's essentially no useful quantitative information from the hospitals, but there is some qualitative information there. But almost 100 participants responded that they were receiving notifications now and filled out responses for how their satisfaction and how they're receiving notifications. So we did learn something there. And then we conducted a number of interviews. We started with talking to the plans. We're continuing to discuss with other organizations as we move forward to get a little bit more detail about some of the things that they're saying. So that's the sources of information in the following slides. Let's go on to the next slide, please. So let's talk about this. What we're going to do now is we're going to talk about event notification from three separate perspectives. The perspective of the source of notifications, so the hospitals, emergency departments, and if they choose to participate, the SNFs. I say hospitals and EDs here everywhere, but this also applies to SNFs that might be using a QHIO to do event notification voluntarily. Then we'll talk about the recipients, and then we'll talk about the QHIOs. And we're going to pause after each one of those to talk about what, to discuss what we've learned through that. First of all, hospital and ED requirements. Hospitals are required to accept requests for event notifications, such as a roster. Rosters they must support. And the roster must include the required purpose for which they're requesting an event. And even if the roster comes through a QHIO, must have the original name of the organization that's making the request on it. They must share admission and discharges for patients receiving care in their facilities in real time. And they must do that with all authorized participants to request them. So it's a large body of participants potentially. They must send event notifications in a particular format using a particular standard with certain data that must be required. They can send them other methods if it's acceptable to both parties. And they are not to charge the participants to receive event notifications. That's in the fees P&P. So those are the requirements for a hospital. To go on to the next slide, a little bit about how they're using QHIO. So as I said before, 80% of acute care settings voluntarily choose to use a QHIO to send event notifications. QHIO use is completely voluntary. So 80% of the hospitals chose to contract with a QHIO to undertake this work. 25% of acute care settings are using a QHO for event notification, but not anything else. That they have chosen to use a nationwide network, for instance, to query for information, but they chose a QHIO for events. Probably at least in part because nationwide networks don't support events, but it does illustrate that organizations that rely on the nationwide networks are still willing to use a QHO for event notification. Acute care settings using a QHO, 98% use 4 of the QHIOs. So nearly all hospitals are sending their events to 4 of the QHIOs. And the 4 QHOs used by the majority of acute care settings receive 99% of all of the events that are carried by QHIOs. So what we see there is that QHIO space on the hospital side is dominated by 4 of the QHIOs. You'll see in these slides that sometimes I talk about 4 of the 8. As Jacob said before, officially there are still 9. So, but the important thing here is that about half of the QHIOs are serving the majority of hospitals and receiving the majority of events. If we go on to the next slide, a little bit about the program issues that this might illustrate. So first of all is sustainability. Meeting the event notification needs of acute care settings may require some QHIOs to make significant investments to receive events. And these may be QHIOs that don't normally serve hospitals and therefore haven't built that capability already. So they're being required to make that investment, and that impacts their sustainability. One of the other issues is service gaps. The business models of some QHOs simply don't include serving acute care settings, that they serve other populations of participants. But they're being required to have the capability to receive events and send notifications, even though they don't support that population. And some of the business models of QHOs don't include accepting and processing events at all. It goes somewhat hand in hand with not supporting the hospitals, but it's just not part of their business. But because of the way the QHO program is constructed, they have to demonstrate those capabilities. So this is going to, if we go on to the next slide, this is our first opportunity to pause here a little bit and talk about what you're seeing in the data from the perspective of hospitals, what you're hearing from perhaps your own constituencies about hospital side issues, and then we'll turn next to the participants. And I'll turn it back over to the chair to facilitate exchange.
David.
I guess what I want to start by asking the question, do we have a sense of what percentage of hospitals have signed the DSA?
I don't have that statistic at hand either. It's the majority, but I don't know what that number is. It is one of the things that under SB 660 that we're going to be working on understanding better.
We'll follow up, Dave.
Oh, I'm sorry, go ahead.
We'll follow up.
Okay. And I asked the question that way because a lot of, what you put up there on the screen makes it seem like things are working pretty well, and that just doesn't jive with what I hear from independent practice physicians. Either the difficulty of getting ADT notifications, the structural barriers that are put in place to getting them, or as you referenced earlier in your comments, getting ADT notifications that sometimes run hundreds of pages of text. Which leads me to believe that either there's something challenging in the data that you're presenting, or it's primarily the hospitals that have not signed the DSA that continue to be the problem. And I don't know what to say about it past that, other than just I hear that consistently from small practices who are the ones trying to get these feeds.
David, one of the things I'd like to do is revisit that thought when we talk about the participants that are receiving events, because the third choice there is that it's broken at the notification stage and not at the event stage at the hospitals. And I don't know for sure, but let's revisit that thought.
Okay, fair enough. Okay. Thank you. Yeah.
Ali. Oh, well, yeah. Let me go Ali first. Sorry, Aaron. You're next.
I also want to share some numbers as well on the ADT notification. For example, on average, we are receiving about 4 million ADTs from Manifest Medics. I'm sorry, that's the outbound. So we are sending 4 million ADTs to Manifest Medics. We are receiving a lot less than that in the inbound, which is about 30,000. So there's that I'm just using that as an example. There's an imbalance in terms of this reciprocal data exchange. Obviously some QHIOs, they have no ADTs to share. So that's one example. Now, these ADTs, it's costly to share this. There's no obviously funding for this, right? So it's a cloud-based system for all the QHIOs and any of these ADT exchange. Other than building the interfaces, there's a cost associated with maintaining and forwarding this. But going back to the earlier comment about where does this ADT go, to David's kind of question is that we don't know who utilizes these notifications and what is the role there. And that's the question that we've expressed. It's all based on the roster, but we don't know if anybody is following up on that. And if they're not following up, why are they receiving? If they don't have the resources, and that's the issue, that providers, they don't have the resources to follow up with the patients. And then that goes into another conversation where healthcare is practiced differently in different parts of California. So in our area, mostly the IPAs and MSOs need to get those ADTs. That the other providers, they don't need to get ADTs because they are doing the more of the care coordination. So we are sending ADTs to a lot of organizations, but the organizations that actually need it, I mean, they're receiving it and they're taking action on it. But I'm just saying that there's a lot of ADTs going out. Nobody is using it, and it's costing QHIOs for processing this data.
Thanks, Ali. Aaron, did you have something to share?
Yeah, just a question, Rin. So on slide 66, when you say that it's not in their business model for some groups they don't serve acute settings, or some don't have sending events to acute settings in their business model, but are they still, because they're acute HIO, are you saying they're not sending or receiving ADTs at all? Or are you saying that because they're acute HIO, they have to send ADTs, even though that's not part of their business model at all?
It's closer to the latter. What the QHO program required when it was established is that all QHOs support all exchange types, which means that all QHOs have to be able to receive events and send notifications. What we found is that when some of the QHOs applied to be part of the program, They might only support plans. Those are their primary customers. Well, they don't get hospital events from plans directly. Well, they can, but plans are not required to send them those. Or there are some organizations that primarily support the ambulatory setting. Well, they don't get events, acute admissions to a hospital from their ambulatory settings either. So that's what I'm talking about there, is that there are QHIOs that specialize in a particular customer set because that's their business model and that's the services they're providing, that don't include hospitals or don't include receiving events.
Got it. So there may be a incurring cost, but for no apparent reason, causing like waste in the system is what got it.
And then Aaron, just to highlight QHOs are required to demonstrate capabilities that they can do this. They don't necessarily need to serve a hospital, but they need to demonstrate capability that they could serve a hospital to provide event notification services. So they need to build the capabilities, even if they're not generating revenue on those capabilities.
Thank you. Okay, we're going to go online. Lee, did you have a question?
Yeah, I just had one sort of concern I wanted to express and then an observation. The concern is that the discussion we've been having about we don't know where these events are going or where who is actually able to use the ADT data is. I think that I just wanted to point out that this is also a privacy and a security concern. Because people should not have data that they don't need. They should be dumping the data that they don't need in repositories of sensitive, if not HIPAA, data throughout the system in places where we do not know where it is and do not know how it is being used is not good data hygiene in the first place. And the second point is just that it is interesting that the discussion that folks are having about networks and how the network is functioning at a large level is somewhat reminds me of the early history of the the phone system because the pattern right, we do not directly call each other. We call each other through intermediaries, and that will often the actual communication traffic of everyday communications, whether it's email or phone, is between the sort of the common carrier equivalent of a QHIO, that the intermediaries are the ones, and whether it's a hospital or a person, we're all sort of at the end of those networks. So a lot of the things I'm hearing sound like large network problems where, for 50, 60 years, a lot of what AT&T and the independent phone companies were just messing around about, and what the FCC was for was making sure that everyone was getting paid for the traffic they were carrying, and that the different companies were like getting reciprocal compensation for data movement. Now, obviously, the movement of communications data on a commercial system is not the same thing as this, but from an architectural or from sort of a network management standpoint, there seem to be some similarities, because nobody wanted to carry more traffic than they had to, and they wanted to make sure that they were being adequately compensated for traffic they were carrying for other folks. So, yeah, I don't know. There may be things that we can learn from like classic network engineering. So I'll shut up. Thanks.
Thanks, Lee. Just quick point of clarification. You had mentioned, Rim, that on the initial roster, the name of the organization that is requesting the information has to be listed. Is that correct?
So that's one of the gaps here, is that that was identified as an issue, that the roster didn't necessarily include the name of the organization or the required purpose for use. And that was identified back in 2024, pushed into the technical standards advancement process, and became new requirements to include those two in all requests taking effect in 6 weeks. So it's one of the downsides of the long process of adopting new standards. So part of Ollie's problem is that the requirements to become effective in August aren't in place yet.
Yeah. And
You need to see if that's going to solve this problem.
yeah, because I was trying to understand your problem. Is your problem that you don't have any idea who you're sending to, or is your problem that you don't know if the primary care physician, for example, is acting on what they got or even looking at it? Because those are different.
They are different, and I think both applies in both.
Yeah, because I don't know for sure. It feels like this committee's scope to solve the first. I guess I think to solve, I mean, we need to consider the second and what that looks like, but I mean, that's pretty substantial to now be telling everyone in primary care what evidence-based protocols they need to have to be doing things. I think it's more like, how do we get them the information in a way they can use it, right? Not like, how did they tell us what happened? Yeah, okay. We got someone else on the phone, Andrew.
Sorry, apologize for my technical difficulties. Yeah, do you got me?
We do.
You guys have me? Okay, great. Thank you. I had two comments. One is just in the context of the basic patterns. This was slide 59. We, as a health plan, receive notifications not only through our 3 QHIO participant or partnerships that we have in San Diego, LA County, and with Manifest, but we also get them directly from the hospitals that we are in partnership with. In terms of volume, I wouldn't characterize it as 80% through a QHIO. It's more varied than that. But more importantly, going back to the prior slide around the technical requirements, I mean, we have these regulations that apply to us about what is supposed to be included, the format it's supposed to be included in. And the reality of it is what we receive and the timelines in which we receive it upon vary greatly. So, and this goes to other parts of the work of this committee over time, but just because it's written on paper doesn't mean it's actually happening. So there's a supposition happening here that, well, the requirement is this, and so everybody's doing that. But in practice, the baseline pieces of it aren't, which complicates the work that each of the intermediaries, whether it's a QHIO or some other entity, or if it's just directly between us as a health plan and the hospital system, it complicates that data and the quality of that data exchange and the ability to use it and materialize it as into actionable information to support our programmatic requirements. So I think it's more than just that all the things, and I think Rim did a great job of articulating some of the broad-based challenges, but at a baseline, are we actually sending the information that's consistent? And that remains a challenge for us as a health plan.
Great, thanks, Andrew. Julie, did you have a comment?
Yeah, I think I'm just a teeny tiny bit confused about the technology and how the actual practice is working. Because right now what I'm hearing is that you have 2 health providers who have people's PIN numbers. And why isn't there a data match? Who do we have in common in real time, once a day, once an hour? And then you get sent back, here's all the names we have in common, and that QHC knows who's in the ER or who's been admitted or who's been discharged. So I'm very confused of this ginormous set of rosters that gets held, and then every time they have an adverse notification, you're sending it. Why aren't you using data matching to be able to see who you have in common in real time?
So there is data matching going on. The roster is me making a request that anytime you see this patient, the thing to remember is you may never have seen that patient today because nobody in Sacramento has ever seen me here. But if I go out and collapse in the parking lot, the ambulance picks me up, there's going to be an ED in town that has seen me for the first time, but has a standing request that they send a notification for me. So they don't have that match happening at the time they receive the roster, but at the time of the event, they do have to make the match. So they are done in real time each time an event happens. Is it on a roster?
Who's holding the roster?
The hospitals here in town are holding rosters, or the QHIO that is serving them.
Okay. So I'm still confused why they're not only doing the match with the folks that are actively needing to be information shared.
Because they don't know who's gonna walk in 5 minutes. So if you are saying I'm a primary care physician, I have a panel of patients, and it is sort of my job to know if one of my patients gets admitted and I need to bring them home, or they're in the ED and I need to know what their diagnosis is and how to follow them up. So of my panel that I'm responsible for, I'm telling usually the QHAO, or the hospital, these are my people. So if you see any of them, then please send the notification to me. I mean, but if I waited to say,
it can be auto pulled every time through an API, right? Why?
Well, it could be, but that means that I would have to pull the entire roster every time there's an admission, or there are other models
that you have.
But this is a
I'm
version of a publish and subscribe model. I am subscribing to your hospital to send me notifications anytime you see this set of patients, and that's the model that's been put in place.
And that's and it's where's the group? Where's the doctor's list being held? Is it being held by the QHIO? Is it being held? Where is it?
It's held by a QHIO or a hospital. If the hospital is using a QHIO, the QHIO holds the list. If the hospital is not using a QHIO, then the hospital holds the list.
Or it could be like a national network like Epic Care Everywhere Exchange. A network of links are built between, so if I see a new patient, the system searches for other hospital systems within 100 miles and says, do you know anything about this patient? And once there's a link, then if there's an event, it'll send a message to that linked organization to say, send a message to the PCP of this patient, which may not be correct. So I may get messages as a PCP for a bunch of other people's patients. I don't even know anything about it. It's not something I actively subscribe to. So, and this kind of illustrates that. I like the idea of publish and subscribe, but it's hard to automate. We don't have national healthcare identifiers. We're going to run into, a lot of Maria Gonzalez's is going to get patients' data mixed up. So it's a really tough problem, but a really important one to solve. I think, looking at this with a fresh, clean sheet design really established what we need to accomplish to get this right. I think it'd be great to do it in California because TEFCA doesn't seem to have any plans published, at least, to take on this use case of data exchange. Maybe this is a place where California could lead.
Great. Thank you. Yvonne, did you have a comment on the phone?
Yeah, so speaking for, I have not heard any issues coming from our SNFs members about event notification. But that said, I think most of them, I think somebody else said most of them are probably not using QHIOs. About 80% of our members, my understanding is they use point-click care. So that's kind of a separate system. But I did have a couple questions. One was, what is the cost per transaction here? I'm just kind of getting a sense of it. Is it like how is this paid for? And when we talk about kind of data being sent, is it a significant per transaction? Well, I don't think the individual transactions are a significant cost, but in the aggregate, is that a concern that there's a lot of notifications going back and forth that nobody is using and it's creating cost in the system? And then my second question was, again, sort of my lack of understanding about the process is, when you say a notification, is the EHR itself just updated? Oh, sorry. I think I just lost my sound again.
No, you're there.
Okay, sorry, I just heard a beep on my. So, is the patient's individual EHR updated to say yes, they were admitted to the hospital, or is it a separate notification? I think I'm just not understanding process-wise how this works.
So two questions there, just real quickly on the first one. I don't have any definite price information, but one of the things that we'll talk about in a minute, in the participant survey, 60% of recipients identified cost of a QHIO as a barrier. So there are a significant portion that believe that cost is a barrier to participate in this, but not all of them. To the second question, that is dependent upon the services of the QHIO or the hospital that's providing events. There was strong opposition to calling out a specific way to send notifications. And so the technical requirements for Exchange do not identify the specific method for which notifications must be sent.
What do you mean by
Call out
method?
that HL7 messages are required to be supported, but other things could be done as well. So I think the desire is that if you use an EHR, that yes, it would land in the EHR directly. But we know that there are some participants that find their notifications because they log into a portal every morning. There are some, I'm going to say it out loud, receive a fax every day with a list of the individuals that were admitted to the ED or the hospital the day before.
Okay. Those are the two. Okay, great. All right, Ali.
So in terms of the cost, it varies obviously by QHIO. We all have subscription model, and this ADT forwarding is, at least in our lanes, is part of that subscription. So that's, each QHIO has a different pricing. But how this works in reality, when it works well, is that the QHIO has a panel list or a roster. And so when we receive a admit to the hospital, we generate an event notification to the PCP or the designated IPAs or MSOs. And what they do is that when they receive that and they act on it, is that they get the information and they put it within their system or import it within their system. But then what they do next is that they look at the discharge summary. They look at the supplemental document that comes from the QHIO again, or they can query the network, the national networks. But they go hand in hand. They get the notification, and then in order to do their follow-up, and the next step is they get the discharge summaries and the supporting documents, and then they do schedule a follow-up, 7-day follow-up, 30-day follow-up, or they just do the medication reconciliation on the phone, and that patient is okay depending on the condition. So that's how it works, and it works really well when there's somebody out there to take action on those ADTs. And I guarantee you, we've done a lot of white papers on this, that we've reduced ED visits because of that notification and follow-up, timely follow-up that we've done in LA.
Great, thank you. It looks like Taylor has one question, comment.
Thank you. Yeah, I wanted to go back a few minutes to a comment that was made, and it says maybe parking lot, but we would love for the committee to come back around and think about long-term what we might do and what might be accomplished around establishing a common or universal patient identifier, and the value of that long-term in addressing a lot of what we're talking about right now, but a number of other challenges and barriers as well. From our perspective, when we think sort of long-term ideal state, that is a component that we think could be immeasurably helpful and help with a lot of the challenges we're talking about. So not exactly the core of the conversation this afternoon, but would love for us to keep coming back to that.
Great, thank you. Oh, okay, Aaron.
Sorry, I'm just curious from the QIOs that are here and working with each other, have you identified any other method other than roster sharing which would be better than that scenario? or unless we're going to talk
We
about
do-
that.
We have some information on that as well. And I think we need to, I hate to break this to you, but this is the simplest of the three perspectives. So we have a lot to go through, but we will come back to that. And if you still have your question, Aaron, after we've touched on that, would you bring it up again?
Great. All right, back to you, Rim.
All right. So if we go on to the next slide, we'll turn to event notification from the perspective of the participants. These organizations are actually receiving event notifications. So what do they need to do? Their requirements are they need to identify the individuals for who they want to receive event notifications. Again, our stakeholders have said, don't send me data I haven't asked for. So they have to make a request for those events. They can do that through rosters. Every hospital in QHO must support doing that through rosters. They have to understand how to submit those requests. So they need to dive into the participant directory and find out, I want to get requests from Hospital X. Hospital X uses a QHIO. So I send my roster to a QHIO, or I send my roster to my QHIO who forwards it on or something. But they need to understand how to make that submission. They must be able to receive and appropriately use event notifications. So they have to have some technology that allows them to get that. As we said before, hopefully that lands in their EHR. Hopefully it does not land on their fax machine. And they must be able to request additional, or they may want to be able to request additional information. Again, on a discharge, they're not receiving a discharge summary, they're receiving an event. A notification that a discharge took place, and if they want more information, then they use one of the other exchange methods to get more information about that event. So let's go on to the next slide. So how are participants using, that are receiving events, how are they using QHOs? Well, 45% of QHO participants are receiving notifications today based on what we're hearing in the participant survey. This information is not available in the participant directory. So this is based on the survey. And an additional 40% are interested in receiving them, but don't yet have the capability, the technical capability. So that just demonstrates that there are a lot of participants out there that actually do want events. And nearly half of them are receiving events today. 65% of those participants that are receiving events said that they're interested in receiving events statewide. That is opposed to, I just want to know in my own little community when RIM is admitted, but if RIM flies down to LA and is admitted, I still want to know about that event. So 65% of them are interested in statewide. And that just underscores that statewide event notification is important to a large percentage of our participants. Only 55% of participants are satisfied with what they get. And David, I think this starts to speak to you. Well, 80% of hospitals are sending them into QHIOs, but only 55% of participants like what they're getting. Now, are satisfied. Some of that is, I'm not getting all the events I expect to be getting. I am seeing poor data quality in the events that I'm getting. There can be many reasons for dissatisfaction, but I think it does underline what you're hearing is that while the hospitals are working with QHIOs, the participants don't like what they're getting back out. 85% of the participants use a QHIO to make their requests and receive notifications. So a slightly more higher percentage of participants are receiving notifications than hospitals are using them. Because there are so many participants, that 20%, it's a large number of participants that are not using a QHIO. And then depending on what the measure is, 40 to 60% of participants are satisfied with various aspects of how their QHIO is operating. Again, 65% feel that the costs are too high and are a barrier. So if we go on to the next slide.
Hey, Rim, just to clarify, the participants are, it could be a provider, a practice, but it also could be a health plan. That's right. It could be, okay, so broad.
And it could be a CBO. It could be any participant that is authorized to receive events.
That's what I just asked to send. Some of that dissatisfaction could also be too much information, correct? Like ED admission, ED discharge, hospital admission, ICU transfer, floor transfer. That's also dissatisfying. So we need to make sure we get people what they want.
And that is an important distinction to make, is that the rosters or the request for notifications was put in place to try to cut down on the noise that I don't want, but isn't being particularly successful. And we've heard that more anecdotally than we have definitive information on it. But providers that have turned off event notification because I can't deal with the noise and I don't learn anything because of the high volume of noise. So, David, there are both sides of that one.
Yeah. Sorry, and so I can jump in on this point. On the too much information side, what I actually hear from physicians is one of the oldest known problems with electronic medical records. I get 1 page of what's happening with my patient and 70 pages of auto text. It's outside the scope of this committee to fix that problem, but it is a problem. And to your point, Rim, some of the physicians I talk to do turn off event notifications because it overwhelms them.
And that is part of the motivation by asking that notifications be just a description of the event and nothing more. But, there are different schools of thought there as well, that, I should be automatically receiving a discharge summary. So.
Okay.
On to the next slide then.
Yeah.
I'm sorry, did you have another question? So what are we seeing about program issues from this side? So first of all, sustainability comes back. Variability in QHO business models and service focus has limited some QHO's ability and willingness to receive and process large rosters. You can imagine that, and we hear about this several times, that if I am a relatively small organization and a plan hands me a roster with tens of millions of patients on it, and my normal patient population is 1 million, that is a huge burden to be doing the real-time matching against rosters for all of those. And there are significant costs with building up my infrastructure in order to support the very large rosters. You can imagine that if you're receiving rosters from several plans, you may have the entire population of the state of California on rosters. That is a potential. Again, with sustainability, many participants believe that QHO costs are too high. We talked about that already. These are relatively small organizations, most of them, but the services they're offering do cost money, and they do have to recover that money in some way. So there is a sustainability pressure there. On service gaps, some QHOs have very few participants using them to receive notifications. If we look through the numbers, most of the participants are using a relatively small number of QHIOs to receive notifications as well. It's not quite as biased as hospitals, but it's still biased. And some QHOs may not support rosters. And while it's required, as of August, it will be required to support rosters. What we're hearing from surveys is that some of the participants are using QHIOs that don't support making requests through rosters at all, and they receive notifications automatically. Finally, and we've talked about reciprocity here in the room already, but when you have QHIOs that don't receive any events but want notifications, that there is a cost associated with receiving the events from a hospital and revenue opportunities associated with sending notifications to your customers, and that the mismatch of organizations and the type of customers that they support produces a problem with reciprocity. Really means that there is an imbalance in where the costs are across the QHOs and where the revenue opportunities are across the QHOs. I think that's where we're pausing for more discussion.
Yeah, there's one question in the chat. It looks like it's from Lee. How are participants charged by the QHIOs is the question from Lee. What's the model? I don't know if
I don't
that's
have
Ollie
details
or-
on that. I don't know if Ollie wants to speak to
It
that.
looks like Lee's question is, how are participants charged by the QHIO? Like, I don't, Lee, do you want to come on and
Yeah,
be more specific?
wanted to understand what do they pay, like a flat fee per month? Do they pay based on like a minimum and a fee plus the amount of traffic that's processed? I just want to understand how in general, because we've been talking about how hospitals or small providers think they're too expensive, and I just wanted to understand how is it that they are charged.
So it's a subscription model. Most of the QHIO have a subscription model. It depends on the type of the organization. So FQHCs, community clinics, tiered pricing from small doctor offices to large FQHCs. Hospitals are priced based on their revenue. IPAs and health plans are based on PMPY. I can't give you a range because the QHIO pricing is different, but I can give you, for example, for lanes, FQHCs starts from 3,000 for 10 providers to 20,000. Managed MedX, just to be fair, PCPs, I don't think they charge for PCPs, but there are other associated charges. Yeah, so that's the range, just to give you an idea. It's usually, for hospitals, probably somewhere between 20,000 to 120,000.
Based on size.
Yeah.
Okay.
Based on the revenue.
All right, Lee, does that help?
Yeah, I mean, and there's no rate regulation, there's no tariffing, there's no it's a completely sort of market based.
Yeah,
it's
that's correct.
industry based, yes, and we are pretty much aligned with other HIEs in the other parts of the country.
Okay, yeah.
If I can ask that there was actually one more slide that if I can get.
Oh, sure, yeah, do it.
2 minutes, we can back up to slide 72. There are 3 other issues that we see here that, first of all, in some of our discussions, especially with plans, we find that plans are often needing to contract with more than one QHIO. So that happens because the QHIOs aren't sharing events or they're needing events from specific QHIOs. The bottom line here is that participants are disappointed that they can't go to a single QHIO and get all of the events, all of the notifications that they expect. So there is a clear failure here in a statewide event notification network.
That was the vision, correct? I mean, they're not confused.
And the other oversight limitation here, potentially at least part of the cause for that, is that the QHIO program did not establish the standards or the triggers that QHOs would share information, but allowed the QHOs to collaborate, to make decisions on how they would communicate with each other, and differences in models and capabilities have awarded that as being terribly successful. So there are additional issues that we see here, all of them resulting in that relatively low satisfaction rating across the participants. Sorry for that.
No, that was very helpful. Thank you. Okay, it looks like we have Aaron. Aaron, do you have a comment?
Hi. Is there any context around the sustainability of participants believing QHIO costs are too high, like too high compared to?
It was a survey result. We'd asked in the survey, how do you feel about certain things associated with your use of a QHIO? And 65% of the respondents thought that the QHIO prices were too high. I don't have any other context for that.
Okay, because I could see compared to another method of complying with the DxF, not complying with the DxF, like 0 compared to something that would be high. I think context would be important to find out there.
What I will say is anecdotally in talking to some of the plans that had several methods by which they were receiving event notifications, the QHOs were not at the high end of those costs. They were at the low end.
So Robert, do you have, I mean, Rim, do you have the information about like the type of person who responded to the survey, or was it like, because I mean, I think it would be helpful to know if, that's a small independent practice, or is that mostly health plans, or is that across the board? Because, in thinking about structures in the future and sustainability models, I mean, I think about like MX has a model that actually to promote the sign up of primary care, doesn't charge very much, or I don't know what their rates are, but they're low, but they charge more somewhere else, right? Like, so I just wonder if there's any more insights we can gain somehow.
We had asked, so the survey was anonymous, but we did ask organizations to declare what type of organization, the response, what type of organization. And I'll just tell you that I don't believe that many CBOs have an EHR. So I really believe that the way people are responding to their organization type is not very clean in the survey. And so we really don't have anything reliable there. It's unfortunate, but I don't know.
Okay. It might be like something for us to think about.
It is one of the things
it's
that we
hard
want
to inform.
Right.
Okay. Got it. I think David is next. Sorry, Scott. Oh, you were going to talk about that? Can he go before you? No.
Yeah, real quick comment. A number of the hospitals I've talked to about it, it's more of a value proposition. It's not that they can't afford 100,000, but there's other things they'd much rather spend $100,000 on. And a lot of hospitals are strapped right now. That big hospital bill going up there. That's why we don't want to pay up for a QHIO.
Okay, great. Thanks, David.
I'll give another piece of quick context on the cost issue. Because I find with independent practices, the sticker shock is actually not the cost of the QHIO, it's the EHR integration. Those custom interfaces that are often required in independent practices it is obscene what the costs are. In theory, that is information blocking for an EHR vendor to charge the cost that they are. But the next time I see that enforced will be the first.
Thanks for bringing that up. Julie.
I'm just wondering, I think I'm hearing you talk about a vision of a state system, and I'm wondering if one of the things we want to put out there or think about is testing this with hospitals and the Medi-Cal managed care plans and coming up with a system that can figuring out what the problems are and what the solutions are. Take the QHIOs out of the picture for this direct. They already have the SIN numbers for their folks, and be able to try something that way, which has a little bit of state control because they're all governed by DHCS or HHS, rather than try to solve the private market problem, which is, I think, partly what we're doing. And am I missing a point here when I'm saying this?
No, I hear what you're saying. And yes, we are trying to address both the public and private market.
Yeah. So I'm just thinking like, how can we carve out a piece to get better at that piece and then ask everybody else to take up all the lessons learned from a smaller group? Of thinking that one, since it's governed by state agency.
Yeah, I don't know. I mean, I'm curious. I don't know, Lynette, if you want to say anything, but you don't have to. I just.
Well, I've said it before. We can pay for Medi-Cal.
Okay. Yeah. Okay. Ali, is Ali next? Okay, Ali.
Yeah, regarding cost, I think what we've noticed is that when there's a funding, then there's no problem. People like HIEs and they value HIEs. When there is no funding, I think the value is not recognized that much. So that's, I'll stop there. Thank you.
Scott, is yours still up or okay? I was just curious, like Lucy, because I'm thinking about health centers and the value piece, because you've made comments that the kind of some of the goals are to participate in value-based care, draw down additional dollars. So I'm curious how you see, this idea of like where you're thinking of QHIOs to help folks be successful in that domain and get more revenue. So that's like a value proposition.
Absolutely. That's exactly what we share information with the health centers. It's if we increase our quality, we increase our pay for performance, we get revenue from other streams, and then it would allow them to be able to pay for, these HIEs, which right now I'll tell you they're like struggling. We hear a lot. The first iteration of QHIOs, we had the funding, it was great, but now there's nothing. So we're really struggling to be able to pay for the HIE. There's one health center in particular that we were able to get them directly connected with one of the QHIOs to reduce their insurance cost. So that was something that we were able to successfully do for that health center, and now they're connecting with the QHIO, which is really exciting. But that's one of the messages that we try to send home is if we increase the quality of data, then you're going to be able to increase incentive payments and be able to, pay for these other things that they're struggling with. But absolutely.
Thanks. Ollie, you got to follow on there.
Yeah, just another kind of data point regarding the cost, and that's the cost on QHIO side is that, for example, organizations like Kaiser, 14 million queries that they've done in the last 6 months for lanes. They're not participating in any QHIOs, I believe, and they are obviously benefiting from the program without contributing to the program in a meaningful way.
They're in the 30%, right? Room? Like that would be an example. Yeah. Okay. Yeah. Thanks. Other folks, I think. Okay.
All right.
You're next.
Next, let's move on to our final perspective, which is the perspective from the QHIOs. Should be slide 74. PowerPoint is not always your friend. Everybody close their eyes. I don't want. All right, so there are two sets of requirements to bear in mind with QHIOs. They have the requirements established in the technical requirements for exchange, which they may be meeting on behalf of some of their participants, but there are also requirements in the QHIO program itself. QHIOs are required to support hospitals, EDs, and SNFs in sending notifications to admissions and discharges in real time. And that may include receiving rosters on the behalf of the hospitals, matching events to rosters, the real-time matching, Julie, that we were talking about, and or sending notifications on their behalf. They're required to support participants in receiving notifications. They must ensure event notifications are exchanged only for required purposes. That'll be a new requirement that begins in August. Under the technical requirements for exchange amendment, and they must collaborate with other QHOs to develop the standards and triggers, et cetera, that allow the QHOs to share information when they need to. When a hospital is using one QHO and a participant that wants events from that hospital is using a different QHO. Optionally, the QHOs may also supply additional information. You can imagine that a physician might put in place a standing request to get discharge summaries every time there is a discharge for anybody on my roster. And therefore, the QHIO may offer as a service to automatically request discharge summaries. Not a requirement of the program, but we do know that some QHOs are either doing that or exploring doing that. If we go on to the next slide, and I want to emphasize, especially that first bullet there, they must support hospitals and participants. That's a QHIO program requirement that pushes that on all QHIOs. So QHOs today, we talked a little bit about it appears to be working, but some people are dissatisfied. QHOs collectively receive more than 90 million ADT events quarterly. including 3.5 million admission events, 7.2 million registration events, and 11 million discharge events. You will notice there that there's a little bit of mismatch in some of those numbers. That just goes to show you some of the noise in those messages coming out of hospitals that QHOs are having to deal with, and that the cost associated with receiving events is not just building an interface, but trying to understand what's coming across that interface. But there are a large number of events that are coming in. Also, what you'll notice from those numbers is that there clearly is some duplication, because that's more than the number of admissions in California in any one quarter. So there are lots of duplicate information that the QHOs are also having to deal with. Very high volumes there. QHOs collectively send approximately 20 million notifications quarterly. So that's things that are going out from the QHOs. So there's a lot of traffic going out also. So it's interesting when we hear that organizations aren't receiving notifications, but the volumes are high. So there must be some mismatch there someplace with folks that are getting what they want and folks that aren't getting what they want. As I said before, there is some imbalance between what each of the QHOs are doing. 4 of the QHOs receive nearly 100% of admission, registration, and discharge events in California. Of the ones from hospitals are using 99 more. If I rounded the number, it rounded to 100%. It's more than 99.5%. 4 QHOs also receive 98% of requests for notifications. That most of the requests are coming in to just 4 QHOs. And 4 QHOs send greater than 99% of the notifications. So this space is really dominated by 4 QHOs. And it is the same 4 QHOs for all 3 of those statistics. Now, unfortunately, after 2.5 years in the program, only 33% of the QHO to QHO exchange is implemented today. Speaks to the requirement of the QHOs to cooperate with each other, to identify how they're going to send information among each other, and that has not been a successful approach. And then several of the QHOs, as we've heard today, several of the QHOs are refusing to share events and notifications, with one of the QHOs accused of allowing some of its clients to misuse that data. Still just an accusation. So there are issues with the QHOs communicating, sharing data with each other.
Wim, can I ask for you keep citing the 4 that are doing the bulk of the exchange and these stats. What are we to understand about the folks who are not the 4? I guess is there some other role that it's just hard to quite get
So as an example, one of our QHOs serves primarily plans. So they receive
Okay. I see. Okay. So it's sort of client centered. Okay.
A lot of that is difference in the clients and also the size of the organizations. A very small organization that only serves a few tens of customers won't have high volumes.
Right. Yeah.
Notifications. Let's go on to the next slide. So we'll talk a little bit about the issues. Sustainability. We've talked about sustainability several times, but variations in the customer base, service offerings, and lack of reciprocity create sustainability challenges across the QHIOs. Again, a lot of mismatch of where the costs are and where the revenue capabilities are. Service gaps, what we just talked about now, is that some of the QHIOs, while they may be have the capability of receiving events, actually don't receive events today. And so there are changes there. And then we've talked about reciprocity several times. The mismatch with an organization that receives no events, but wants events from other QHIOs so that they can send notifications, causes an imbalance in the cost benefit across the QHIOs. Let's go on to the next slide. We really are in the home stretch now. Oversight limitations, we've talked about this a little bit. QHOs do not share rosters or events with each other. Limiting statewide exchange is, again, we did not tell them how or when to share data with each other. And the differences in capabilities across QHOs have stifled their ability to really arrive on a good solution to that. There continues to exist trust issues within the QHIO program that is not limited to the QHIO program, but raises its head there. Also, Jacob spoke earlier about that QHOs are not required to monitor the behavior of their participants, but their expectations. Let's go on to the next slide. A little bit of summary. So if we went back over the past slides, this is what we're seeing, that sources have evidence of QHO sustainability problems and service gaps, recipients almost across the board, and QHOs across the board. Anytime you see two X's in one of these boxes, that means that I found two different types of evidence for the same problem. And what you should not read into this is that service gaps is by far the biggest problem here, but that there is the most evidence of service gaps here. All of these are problems with the program right now, but this just kind of summarizes what we're seeing. And to Jacob's point, we have evidence of all 6 of the issues that he raised before. And recipients and QHOs are the ones where those issues are most obvious. Let's go on to one more slide. I want to talk just a little bit about what the outcome of all of this is. So if I am a participant and I want notifications, because not all hospitals use a QHIO, and because the QHIOs don't communicate with each other so that I can just send my roster to one QHIO, that means I have to send rosters to approximately 4 QHIOs, 10 other intermediaries that are not QHIOs but are acting on behalf of hospitals, and more than 80 hospitals that are doing point-to-point connections. That's who I have to deal with as a participant. So more than 90 separate organizations I'm going to be sending rosters to and need to receive notifications from. On the hospital side, it's worse. So on the hospital side, even if I'm using a QHIO, I have to send my events to the QHIO. I have to send the notifications to those 10 organizations that are not QHIOs, and 900 participants that aren't using a QHIO. So as a hospital, I'm sending to more than 900 separate organizations. And this is just not sustainable on either side. One of the big issues here is the voluntary use of QHIOs. The drivers in this is organizations that aren't using a QHIO and are out of the statewide network are driving a problem for those, even those that are using it. If we go on to the next slide, I think we're back to our last session of discussion.
I just wanted to close the loop on a question David asked earlier. You asked how many of our hospitals have signed the data sharing agreement. It's an approximation, but we estimate about 91% today have signed. General acute care hospitals have signed. 91% of general acute care hospitals we estimate have signed the data sharing agreement. We're refining those numbers as we align with Senate Bill 660 to create a non-compliance list. That is our current estimation.
Jacob, and we have like 300 and something general acute care, 400.
Closer to 450.
And that includes both general acute care hospitals and acute psychiatric hospitals that have the same requirements.
Right. Okay, we're going to open this up to further discussion. I guess, okay, you're down. Okay, Lynette.
So just listening to kind of where we're at and all of that, and actually I want to piggyback on something Lucy said earlier. And this really feeds into some of the expectation that I've heard from CMS about how is all of this supposed to be funded? Well, part of the funding is supposed to come because data is delivered. Now you can get an incentive. So now that you're delivering higher level care, you're getting your quality measures. It's about the value-based program initiatives. that that's what we heard from CMS as high tech ended, was the expectation that that's some of where the dollars are coming from to then pay for data exchange. So when you said that, I was like, oh, that reminds me. And so it kind of leads into this question around, what does funding look like? How are services described? And how is that value understood? So if the value that you're getting is because now you're eligible for your value-based payments and your incentives, well, then some of that needs to be shared with the groups that gave you the information to get there. And so, not that we're talking about it this time, but maybe for one of the future conversations, to be able to think about how that fits. But that was one of the really big things about the switch from high tech, which was, we're going to pay you to adopt, technology, to we're going to pay for quality outcomes. And to get quality outcomes, that means you have to have data and information. So you should be spending the money you get for quality outcomes on getting data and information. So just drawing that connection. Yeah.
Thanks, Lynette. Looks like we have Lee online.
Yeah, I just have a really dumb question, which is about the looking at the resulting complexity slide, and how big what is the range of the size of the rosters? I'm wondering, is each hospital's roster essentially all of the patients it has served in the last year, or what is the content of that roster?
We don't have hard numbers on that, but you can imagine that a clinic that has a small number of patients that they're following aggressively might have, dozens of patients on a roster?
Oh, yeah. I would say it's got to be a broad range depending on the client, right? So if it's a practice, you're going to say, oh, it's somewhere between one provider, I'm 2,000 patients, to I have 300,000 patients at a big.
Alta Bates Hospital. I'm just.
Well, I don't know that the hospitals are using rosters, because they're not. They have the
notifications as often as others are. The other end of the spectrum is probably
the plans. Yeah,
large plans may have tens of millions of individuals on their rosters.
That's where the scale.
Yeah, that's a driver of
the scale. Thank you. I did not appreciate that. Thank you very much.
Thanks, Lee. Karen.
I'm just, again, basic questions. I'm a little confused. It seems like you have a whole list of issues with the QHIOs and things that would be better if they happen a different way. And I'm a little lost on whether those are issues because they're not requirements, whether those are issues because you don't have the ability to enforce those requirements. Like, I'm a little, because what I just looked up, like, there are pages of requirements for the QHIOs that seem to track a lot of these issues, but can you just help me understand, like, what the sort of crux of the problem is here with QHIOs not doing various things?
Yeah, I can start and feel free to add. So part of it is we have a limited resource team with limited compliance oversight mechanisms today. So we have relied on QHIOs to attest to being able to meet requirements, but certainly attestations are not a robust means of compliance. And then other things have come up since the program was created that I think we're hoping to learn from and use the advisory committee to create recommendations on, like the trust issues that have come up. We didn't originally plan for allegations of privacy and security violations by clients of a QHIO, and how that might impact QHIOs interacting with one another and exchanging with one another. So gaps associated with just lack of foresight on what could come.
Yeah, it seems like part of it is also just sort of the structure that was set out in addition to the specific policy, right? So it's like, well, what's the, like the competition, like how is the market organized? Like what's the revenue look like? Like what's the business model? Like that stuff that's not in there, and then that causes some of this, I think. That's how I see it. But okay, who we got? Aaron.
Sorry. Once again, back to my question from earlier for the QHIOs. Have you identified a different method other than roster sharing that would be beneficial? Although we saw in the stats that the cooperation QHI to QIO hasn't like quite occurred yet, but I'm just curious if that's been discussed. And number two, I'm adding to it now, sorry, which is how much of the cost is associated with maintaining this very large roster sharing issue? How much of your cost really is associated with that part of your business? And then number three, how would better identity management, which a few have mentioned here, help with that roster sharing issue or potentially eliminate it?
Well, you were next anyway, Ali. So
Thanks. Those were really good questions. I wanted to kind of make some comments about the roster itself, just to put it in context. So the roster sizes come from, in small, health plans, as was mentioned. 2.2 million is one of the ones that we have, and there are a lot more than that at some other health plans. We get those rosters typically from the primary care providers as well as IPAs and MSOs. Those are the ones that are actually taking action on those notifications. Those rosters range from 1,000 to several hundred thousands. I think one of the problems that we see in terms of duplication that was mentioned is that because the health plans give their eligibility file to all of the QHIOs. So there's naturally duplications of ADTs because of that. And then there are some other organizations that are so progressive that they just, they want notification other than the entire panel that they monitor, but if what they want QHIO to monitor, but they want to monitor their diabetic patient. They want to monitor their asthma patient. So their roster sizes, is just the diabetic patients that they want to track. And those are, not sometimes not large sizes. So these rosters come in different variety. One of the costs that you mentioned is that we have to, in order to serve those participants properly, we have to take those rosters and put them into our MPI, Master Patient Index, which is where the cost comes because as we pay per member for those patient identification, or kind of lost my train of thought there, but that's where the roster has a lot of costs for QHIOs for two reasons. One is the MPI, the other one is the storage. It takes a lot of storage to process those. Regarding QHIO to QHIO, we are working with other QHIOs currently for instead of exchanging large roster files, we're going to do the FHIR APIs. So that's where we are right now, and we expect that this FHIR API exchange instead of exchanging sending large roster file, we're using API. That should be live by August of this year, and that's what the QHIO to QHIO data exchange is kind of right now in transition.
Okay, just to follow up on that, is that so the FHIR would be more real time of I got a request for this member, I'm going to real time reach out. So you're less sharing rosters and more just I know Lanes has it, reach out and get it.
That's right. It's an API. I have this ADT, and if I have the roster, I'll pull that information.
And just to clarify on that, so it's not, I know Lanes has it, but hey, Lanes, we just had an event on this individual. Do you have a relationship with this individual? Are they on your roster? If so, I'll send you the full ADT event notification. And so it is, like you said, happening in real time, but these are live pings for every single event, as opposed to sending a large roster file once a month to each QHIO.
Got
One thing that might be a helpful metric as you get your arms around the who signed, et cetera, is there I just wonder if there's even enough juice left in the system to squeeze. So assuming everybody, every entity, every hospital system signed the DSA and they all signed up with the QHIO, would that provide enough dollars into the system to keep the QHIO solvent? Or is there still structural issues there that they're going to have to change their business model and spend less on storage, for example, because it can be more of a federated system? Or, are your costs going up, like cybersecurity? Is that going up? Is that going to become something that can break the financial sustainability of the whole thing?
Okay, I think we're gonna take that back. Looks like,
Yeah, that's good feedback. Thanks, Scott.
okay. I think, is this right? Is this right? Okay. Oh, wait, it's down, yeah? You don't have another comment, okay. I just want to make sure. I don't know. That's right. I'm going to put it down for you in 30 seconds. Okay, we're going to move to public comment. And we're going to start with public comment in the room, and then we will move to the phone. So first speaker at the podium.
Great. Great discussion. And I just wanted to follow up, on RIM's stats saying that the vast majority, essentially all of the ADT exchange that's going on today through the DxF is going through 4 of the QHIOs. One thing to point out is that not all hospitals send their ADT information through a QHIO. The governing legislation doesn't require that. It says it has to go through a HIO, but not a QHIO. And I know I work within the Epic community, and Epic hospitals, for the most part, have not felt compelled to sign up with a QHIO to manage that traffic. So that's where a lot of that is. It's outside of the DxF. The other thing I wanted to mention is that, as Virginia mentioned earlier, Health Gorilla does service Meditech hospitals within California, of which there are 16, Meditech being the 3rd largest hospital EHR, EHR after Epic and Oracle. And as you heard, Health Gorilla will very soon be able to work with the Meditech hospitals to be able to send ADTs from them. A couple of the Meditech hospitals are currently signed up with Health Gorilla to do that. A couple more have not yet selected how they're going to do that. And a number of them have signed up with other QHIOs to send those because Meditech didn't have that functionality to do it directly. So I think there is going to be a shift, so that 4 is going to turn into 5 over time. And so I just thought that was worth pointing out to people.
Great, thank you. Do we have anyone on the line? Akira, do you want to invite the first person?
Yeah. Jason, you can come off mute now.
Great, thanks so much. Good discussion. A few comments. I just wanted to first make it on the record to refute the numbers Ali gave. We do not have an imbalance in the exchange of ADT with them. That's it's really pretty close to equal on those. So I just want to get that on the record. Overall on this topic, hopefully everybody's here on the same page. I think this is generally almost exclusively a business and policy issue rather than a technical issue. And it comes down to funding, right? And so no one is funding this work. I think you've heard that from us repeatedly. Ali bears that message as well. But this is not, we're not dealing with technical challenges for the most part. The one technical challenge that does exist is the roster exchange. And so to give you a little bit of perspective, the roster that MX would exchange with other QHIOs is around 20 million individuals. And that is extremely burdensome. It produces privacy risks, which is why we came up with and developed the FHIR API approach that does not require the submission of rosters back and forth. And so we've actually deployed that across the country with another state and are looking to expand to other states. So we think it's a great spot, again, to say FHIR roadmap. It's something QHIOs are already doing today. There's some national expansion. It's a really, really great first place to start on that roadmap is the ADT. On cost, I just want to say here, like MX, we provide a no-cost path to both providers to receive notifications and to hospitals to deliver their ADT under the DxF. Now, we don't cover our costs on that. That costs us a lot of money, but we want the hospitals and the providers to have compliance in the DxF. And so we do offer that as a no charge service. The last thing I want to reiterate something that Jacob stated about the method for delivery. We treat delivery of notifications as a product, and our consumers dictate how they want to receive those notifications. Some folks want to log into a web portal. Some folks want a spreadsheet. Some practices want to integrate it into their EHR. And so I do agree that we should absolutely not try to dictate that under the DxF, because that really goes against treating this as a product and meeting the consumers, the providers, exactly where they are and what they want. Thank you.
Great. Thank you. We're going to go back in the room now.
Thank you. Felix Su, also with Manifest MedX. And to actually continue the theme that my colleague brought up about no cost, and to clarify a point that was brought up during the discussion on ambulatory providers, small physician practices, we actually, for over a decade, have not charged even subscription fees to cover our costs of providing those connections. We do this because it is part of our mission to make sure that these on-the-ground care teams get the information they need to deliver the best outcomes for their patients. And also the stark market reality that because so many of them are under-resourced or safety net providers, many of them presumably would not be able to afford to engage in data exchange if we or another vendor were to charge them to use these types of services, including ADT notification alerts. Now, where does that leave us in terms of sustainability? We today connect over 100 hospitals, and we deliver 2.5 million ADTs on a monthly basis, more than any other QHIO in the state. Now, in contrast, we've had other QHIOs with only several or even zero participating hospitals request what amounts to a one-way flow of ADT notifications from us to them. That means a massive net transfer of ADTs out of our network to our competitors at our cost with nothing of value coming back. Now, there's simply no way that we can sustain this if we are to be a going concern. And more broadly, there's no way this can be used to sustain a statewide model of data exchange, including and especially for ADT notifications. Now, I'm really glad to have heard Lee brought up the example, the analogy of broadband networks, because we have actually already shared with HCI a policy proposal that would work exactly like network transit pricing in the internet service provider industry, which is that if one QHIO were to request notifications from another above what the requester can reciprocate, then the two should execute a contract in which the requester pays the other QHIO for the overage. This would be similar to Comcast today paying AT&T or Verizon for the ability to deliver net traffic to their end users. If they cannot reach a contract, then the default exchange should be capped at the smaller of the two QHIO networks. We can certainly provide more details, but we really hope that this is taken up as one of the recommendations in the upcoming August meeting for how to actually solve for many of these incumbent issues. Thank you.
Thanks. Akira, do we have anyone on the line to comment?
Yes, we do. Rosaline, you can unmute now. Hello, Rosaline, are you there? If not, Rosaline, we do have Robin. Robin, you can come off mute.
Thank you kindly. Robin Roberts again with Point Click Care. Rim, I want to thank you for your research, sharing all those stats and what's going on. Slide 79, the picture you paint is quite correct. A participant seeking statewide notifications today has to connect to more than 90 separate entities. A hospital providing statewide notifications has to accept rosters from more than 900. I think those are two very salient and illustrative examples of the challenges we're dealing with among the other dimensions of measurement across the program that have been discussed this afternoon. And so One thing I do want to call out is that the listening tour summary in the documents, the engagements with the QIOs, hospitals, health plans, public health, county agencies, does not reflect any direct input from nursing facilities or post-acute providers. We'd just like to surface that because these numbers are correct, but like they lack context has been brought up as other discussions have gone on in the room. It also leaves a meaningful gap where we would ask the committee to please consider future um, requirements that could land on that sector to include them in future listening. We act again as an intermediary today to enable that fast, less burdensome interoperability because we already have a framework to exchange ADTs and CCDs on behalf of our customers statewide at scale. And so, again, we support HCI allowing the QHIOs to specialize and acknowledge the variability between them. There was a documented goal very early on that this was not about picking any one tech winner. It was the goals of the program and its efforts, while we are dealing with a lot of growing pains, are far more altruistic than that. We would ask that you continue to provide non-QHIOs, intermediaries, to still be recognized and fill the gap that is even present in some of these numbers being presented this afternoon, because some of these gaps are being filled by people like us.
Okay, we're going to go back into the room. Hi.
Good afternoon, Dan Chavez, Executive Director of the Survey Communities Health Information Organization. Great conversation, but there's an aspect that's been missing from the conversation today. In establishing an HIE or a QHIO, we get ADT feeds from hospitals, not necessarily for real-time alerts, but for public health reporting. That has not been brought up. So this aspect with ADT from a hospital and its corresponding emergency department is used for multiple purposes beyond real-time alerts. It's also used for public health reporting, electronic lab reporting, immunizations, and syndromic surveillance. So there's an aspect here of economies. If the community, and like Mr. McCann said, at the county level, this can be a very leverageable feed for multiple uses beyond the real-time alerts that's been discussed this afternoon. And those economics and that distribution of data and that robustness of data from those ADT feeds from hospitals can be used much more effectively in a community, way beyond what we've discussed this afternoon. And I'd just like you to bring that to your attention and your consideration. Thank you.
Thanks for that. Do we have anyone else online?
No hands raised at this time.
All right, so Rim, I'm going to just do a little like takeaway here. So can we go to that really crazy slide that we just had up? Okay, so our goal is to start to think about if this is where we are, and we were going to go to your starting slide where you had like a very clear pathway that was complete. It sounds like the charge here to a certain extent is like, how do we get from here to there? Right. So, I mean, just kind of to orient us in, because it's been a long day of a lot of, I think really the intent today was to surface like all of the issues and use this as like our chance to really dig deep and uncover. And going forward, I think as we kind of close out, we'll be really talking about how we orient towards getting from here to somewhere else. So it sounds like we've had lots of questions, some good deep understanding. And thanks, Julie, particularly for like really taking the time and effort to get the clarifications that you need to understand. That's really, I mean, and not just you, but others. So that feels like where we've landed with this. Would you, Jacob, what do you think?
Yeah, I think generally this is, I think, the best illustration of the
crux of it.
The crux of it. And the solution of how we address that is what we are going to convene in August for.
So with that said, I think our time is to move to our last item, right? Yeah, so can we go to the next slide after public comment? Okay, so now we're going to go on the journey to solving, solutioning, becoming something different. So the first step in that, and I know more information will be forthcoming, but HCI and their collaborators have very thoughtfully organized around a webinar July 16th. And really the intent there for the idea was we have a 6-hour meeting. We need to have a lot of discussion, but there's also some context that we would all really want to get to inform how we think about things, and we might not be able to do it all right here. And so, while I think this is a pretty public webinar, I think for us, the opportunity here is to learn a little bit about how other states have structured themselves, and really it's focused on the pipes, right? It's focused on sort of how they have operationalized that sort of front end vision of getting from the hospital to the provider and vice versa. I think that there's been a lot of work to identify what those examples are and who might be good to talk to. And there will be several states represented. I think you're still confirming a couple, but I just wanted to encourage folks, as this is sort of like a different version of pre-work instead of a pre-read. I'm sure it'll be recorded, yes. So if you're, in China or somewhere, you can still watch it. But wanted to just put a plug in for this webinar, and it's really open to everyone in the spirit of solutioning. So is there anything you want to add to the context of that, Jacob?
No, just that we'd encourage you all to join. We want to be on the front lines of ADT event notification, and there's several other states who are doing it well. So let's learn from them.
All right, so see you there. Next slide. Hopefully. Okay, so August. So I think this is where we're going to turn to some of the solutioning. So I think that I will say I know HCI is interested in us continuing to sort of make progress and move towards, even if it's step by step opportunities towards change. And so instead of further unpacking, I think we'll take some time to answer questions and then really move into what are some directions that we should take. And we have some work being done to sort of narrow that down based on the categories we discussed today. I think there's a little bit of a root cause analysis that was discovered in our conversation today that we can sort of think about also as a framework for how to make the pipes work. And we will be really focusing in on some of the ideas that you all may have. And I think if there are examples from other states that have been successful, we'll be able to incorporate that. And if you aren't able to make the webinar, we'll make sure there's some materials available to you otherwise. So that's the plan. It looks like Mark has a question. Mark.
I just want to confirm that the collection of demographic and health-related social needs data will also be at the August meeting. Thanks.
Oh, that's not on there, is it? Anyway, yes.
No, yeah, that will be a separate agendized topic.
Yeah. This was kind of like the through line on this topic, but yes.
Just being helpful.
Thank you.
Right.
Thanks,
And one big takeaway was a sort of non-QIO facilitator of transfer. It'd be nice to keep that in our consciousness.
Yeah, that seems like a front end kind of look or discussion, meaning I don't feel like you'd want to go through and whole design a system and then be like, and there's this other thing over here. So that feels like a front line pathway or decision point probably to talk about. Yeah. Okay, well, that's good. Put it on the list. Anything else? Oh, we're going to go, well, any other comments from the committee? Any questions, anything else you really wanted to get out today before you jump to your happy hour? No. Great. Okay, we're going to do final public comment. because that is very important to hear from all of you. You've given us some great ideas and thinking today. Anyone in the room? Okay. Anyone online, Akira?
No hands raised.
Okay. I think we did it. Thanks everyone for your incredible efforts and time and dedication to the work. And we have a few more slides. We do?
Just with the next.
Oh, let's go next. Sorry. Okay. Yes. Okay. These are our meetings. I think you have them all in your calendar. And thank you again for spending 6 hours a day together. And the topics, as Mark very accurately pointed out. So we have sort of like what's next. And if you noticed when Mike went through the roadmap of the meetings, we're kind of paralleling some topics because it's hard to talk about one thing for 6 hours. And there's a lot to talk about, and we want to give things equal weight when they need it so they can all move together. So we have a section on that will be follow-up from this. We have public accountability, sort of enforcement component. And I think questions about that came out a lot today. So it will be good that we're addressing that. And then, of course, we will have some overview and discussion around health-related social needs data and demographic data, Mark. And that's the first of several planned conversations. Okay. Is there anything else? All right, next slide. All right, I think this is our ending slide for reals. Okay, thanks everyone. So nice to see you. Formally adjourn us at 3:48. Woo! Okay,
right.
thanks.
Congratulations.
Well, 15 minutes early.
Woo!
Look at you.